Hi guys, welcome back. The next topic we're studying is stroke, also called as cerebrovascular accident. The risk factors for development of this condition are gonna be identical to that of what we discussed in cardiology for coronary artery disease. I will first begin by describing to you regarding TIA, transient ischemic attack, in which the neurological symptoms will begin to resolve. The message at the moment is that if neurological symptoms in a patient begin to resolve by 1 hour period, we have to think in favor of a TIA. But if the symptoms continue to increase, for example, somebody had a facial weakness in the first hour, arm weakness in the second hour, and then a speech deficit in the third hour, then I'm not going to call it a TIA because obviously the symptoms are increasing in number. But if I give you a scenario where person had an arm weakness and then it has become lesser by 1 hour period, I'll definitely think in terms of a possibility of TIA. Now, the surprising thing is that the cutoff that they have kept for TIA is not 1 hour, right? The cutoff for transient ischemic attack in which the symptoms will completely disappear is 24 hours. So the first message that I want to give you is that though the cutoff for TIA in the exam should be answered as 24, in clinical practice, if it's a genuine TIA, the symptoms will start improving by the first hour itself. Why? Because the anti-clotting system of the body, that is protein C, protein S, and antithrombin 3 will be kick-started into action, and they will resolve the clot, they will resolve the neurological symptoms. Transient ischemic attack has been discussed even in the subsequent lecture after this, where I have specially elaborated upon that can somebody who's having a TIA, can you predict in a patient what are the percentage of chances that he will develop stroke in future? So we have a scoring pattern available by the name of ABCD2 score. A would be standing for age, blood pressure, clinical features, and reason why it is called as D2 is because 1D is for duration of symptoms, 1D is for presence or absence of diabetes mellitus. But I want to tell you that this score is so accurate that you can actually in a TIA patient predict what is the exact percentage of this person developing stroke over the next 48 hours. Therefore, I have said three terms. I have said sometimes over 1 hour, sometimes 24 hours, sometimes 48 hours, and that is what confuses most of the students. So I would like to highlight the fact, and this is very important for solving MCQs, that if you find that a person has developed sudden onset neurological symptoms, I'll enumerate those symptoms also, but the message at the moment is if you are having an improvement in the symptoms, if there's a resolution, which is usually starting by as early as 1 hour, it implies that we are thinking in terms of a TIA. But if the symptoms are progressive or the same symptom is worsening, then it's definitely not a TIA. It would be a development of a progressive stroke in a patient. If in the exam he says what is the cutoff, then I've already sensitized you to this fact. The cutoff is going to be 24 hours, but the message is loud and clear, guys. If it is going to be a TIA, it should show improvement in the first hour. If it is not, then you definitely have to consider it a stroke and start treatment. Why I have emphasized that twice is because the window period for treatment of ischemic stroke is 4.5 hours. Because the window period is 4.5 hours and the radiological finding of ischemic stroke might take 6 hours to appear, you are not going to wait for radiological findings on a CT head to appear to start treatment. If clinically speaking, a person is having progressive symptoms or worsening of his symptoms by 1 hour period, I will consider that person as a case of, on a CT scan, if it is normal, as ischemic stroke, and I will do thrombolysis in the patient. This concept will become more clear to you as we progress in the discussion. At the moment, at least two concepts should be clear to you. First, the cutoff for TIA is 24 hours. And if you are going to do any kind of neuro imaging in the patient, and mostly in our government hospitals, we have a non-contrast CT scan available, the imaging should obviously be normal. But you have also learned the fact that if the neurological symptoms are persistent or increasing by 1 hour period, even if the imaging is normal, because the symptoms are progressive, and the CT scan is normal, you have to think it as a possibility of ischemic stroke and start thrombolysis. The cutoff of the window period for symptom onset versus the treatment part should be within first 4.5 hours. In the subsequent part of the discussion, I'll also talk about what is the treatment to be done in a case of stroke for 4.5 to 6 hours. I'll provide you technical information for mechanical thrombectomy. And in fact, you can go through the animation part also where I have spoken about it. The learning for you guys at the moment is that whenever stroke will occur, it will occur very fast. So you need to basically make the ordinary population aware of what is gonna be the manifestations developing in a patient. When I say the word fast, the most usual impression in mind of most students, especially in a live face-to-face class when I'm taking, is that maybe I'm going to talk about blunt abdominal trauma. No, obviously this is not a general surgery class. This is a general medicine class. So by fast here, I mean that if any person, irrespective of the age group, if a person develops a sudden onset facial weakness, sudden onset arm weakness, like he is not able to raise his arm. You giving him a glass of water and he's not able to raise his right arm, that's definitely a cause of concern. Then alphabet S would mean speech deficit, like maybe you might notice that his lips are quivering, but there is no voice production per se. That would be speech deficit developing in a person. And most importantly, you see, I will say time is the essence here. Time is when you are going to be saving neurons in the brain. I have equated, normally the impression is time is equal to money, but we doctors are not money minded. For us, time here is neurons. I mean, the more million neurons that you save, the prognosis in the patient will be fast. So let's just quickly remember that fast basically means that if you are going to identify stroke manifestations relatively quickly, then you will be able to get a better prognosis in a patient. For transient ischemic attack, the details are even given in the subsequent lecture, but at this moment I also want you to remember that what should we do in the patient immediately whenever you are suspecting TIA in a patient. Neuroimaging can be done later, but you must start the patient on DAPT, that is dual antiplatelet therapy, that is aspirin and clopidogrel. Last time I have taught you about dual antiplatelet therapy for management of ST elevation MI, and now I'm teaching you regarding DAPT to be initiated even in the case of transient ischemic attack. Along with this, based on the investigations, like for example, you are able to demonstrate that this guy is having a atrial fibrillation. That will cause clot formation in the left atrial appendage. The clot will go from left atria to left ventricle into systemic circulation. So you will have to add NOAC, that is novel oral anticoagulants, for the patient as well. The message is that if you're going to start this treatment, you can prevent the development of stroke in a patient, and the highest chances of stroke development are seen in the first 48 hours after a TIA. I'm not saying that stroke will occur only in the 48-hour period, guys. It can occur anytime, but the highest prevalence is in 48 hours. So look at the values I've said. Improvement starts usually by first hour. Cutoff is 24 hours, and highest chances of stroke are within 48 hours. And you will notice the importance of these as you will do questions, because he's going to talk about all the time frames that I've highlighted. Now let us assume a scenario where a person has not paid attention to the symptoms, and lots of time you see the symptoms might be neglected by the person, or if he's having a low education status, he may not be able to express this to his family member also. In those circumstances, once stroke will occur in a patient, we will obviously have to do specialized treatment, but don't jump the gun and straight away start answering that I'll do thrombolysis or I'll go in for a hemicraniectomy or a ventriculostomy in the patient, because first and foremost, in any patient presenting with stroke, you need to take care of airway, breathing and circulation. So I just want to highlight the fact that the baseline protocol of treatment is to be respected. And also, if he says what is the first investigation to be done in a patient, obviously to differentiate the etiology of stroke, I need to do a CT head. But before CT head, you will also have to do glucose levels in the patient. Why? Because even if he's a non-diabetic, if glucose is too low, hypoglycemia will decrease the capacity of the neurons to handle the stress. If sugar is very, very high, then it will increase the swelling in the brain, guys. We might have to give insulin drip to the patient to actually reduce the sugar values so that you can have a euglycemia status. I want to highlight that whether it's a diabetic or a non-diabetic patient suffering from stroke, first glucose levels should be done, then CT scan in the patient should be done. And you will again use this in a lot of MCQs where the message is it's only once the CT scan report will come, if it is normal or if it is showing a hypodensity, then it is suggestive of ischemic stroke. If it's going to show a white hyperdensity, it's going to be hemorrhagic stroke where thrombolysis is contraindicated. You will have to handle the raised ICP of the patient, and I'm going to teach you these aspects as we progress in the discussion. The main message from this particular part of the slide that is currently on the focus is, in any patient of stroke, take care of the basics, handle the glucose values, then do a CT scan, and based on etiology, treat the patient. Now, once this is clear, we will now focus on how a person of stroke will present to us, and we will here understand what is going to happen if the blood supply of the following areas of the brain, that is frontal, parietal, temporal and occipital, will be hampered. I will first start with damage to the blood supply of the parietal lobe. I am a right-handed individual. Most of you who are listening to me would be right-handed, and in right-handed people, the dominant part of the brain is left. You very well know that the dominance is opposite to the handedness of the person. So I am at the moment focusing on what is going to happen to an individual if the dominant parietal lobe of the brain exhibits a malfunction. Let us assume, I take my scenario itself, the dominant parietal lobe of mine, like I am a right-handed person, like I'll just put that on record, so that the discussion is uniform. For a right-handed person, the dominant part of the brain will obviously be the left side, and the blood supply of the parietal lobe will be the middle cerebral artery. Now, imagine there is an embolus which started from the left atrial appendage due to atrial fibrillation and has landed in the brain circulation. So let us understand what will be the impact on the patient per se. For this, you need to understand what is the important function of the dominant parietal lobe. It is responsible for elementary mathematics like 2 plus 2 is 4, or if you go to any shop and you give a 100 rupee note to a person, of 200 rupees note to a person, you have purchased an item of 50 rupees. So you know how much money the person will return back to you. Basic elementary mathematics. Now, even if I stop talking at the moment, like suppose I become totally silent, or suppose you put me on silent mode, right? You switch off the speaker of your phone. So I'll be speaking, but my voice would not be coming. But even then, if you are just gonna see the words that I'm writing, you obviously can understand English language. So even if I'm not speaking before you, even if I'm not providing you audio stimulus, just by looking, you can see the words written on the slide per se. So you and me have the capacity to understand written text, written symbols. Like you go to the airport, it is written, no, departure, security, etc., etc. So you look at the symbol and then you proceed in that direction. Suppose I have come to your city to take a face-to-face class. Now, once the class is over, I ask you, okay, doctor, I need to go to a particular good restaurant, or I want to go to a particular area. So you can give me directions that, okay, go straight 2 kilometers, then turn left, right. Left-right orientation is again a function of the dominant parietal lobe. Or for that matter of fact, if I'm not asking you, I can just use Google Maps in my mobile, and even the Google Maps will regularly tell you, 200 meters turn left, etc., or take a U-turn. So we can follow directions left and right with help of the activity of the dominant parietal lobe. The fourth and the most important feature of the dominant parietal lobe, all are important. I'll rate that as relatively more important, is the speech output. I mean, human being is all about that you can express your emotions. So speech output is again related to the parietal lobe per se. And unfortunately, in my patient, the embolus has gonna defect has resulted in malfunction of this area. So all these functions would be lost. And now let's look at what's going to happen to the patient. For this person, 2 plus 2 is never ever gonna be 4 again in the life of this guy. That is gonna be called as acalculia. I wanna highlight, like I put it on myself, I was bad in mathematics. Most doctors are bad in mathematics. They have dyscalculia. That is why they take a biology, right? And once they take a biology, at that point of time, you never know that you will get into a medical school, then you have to study medicine, you have to study surgery. At that point, being a doctor is like, being a superhero per se. But one of the reasons I said, on a lighter note, is that dyscalculia in doctors is one reason why actually they become doctors, because they're bad in mathematics, so biology is saving grace for them. In this guy, however, it's not going to be dyscalculia, it's going to be acalculia. Then understanding written text would not be possible in this person. So the technical term that you need to note down here is called as agraphia. Similarly, left to right orientation will be lost in the patient. So if you ask him to suppose show his left hand versus right hand, he will be not able to follow directions. So that would be left right disorientation. Or I can put it a different way, the way the examiner would love to ask it. Like at the moment I'm showing you my thumb. You can note as a thumb. This is index finger, this is little finger, or I can just put up a symbol like this, right? Yo man. The message is you can understand that it was a thumb or an index finger, but if you are asking this guy which finger is it, he will be at a loss to explain that to you. So the technical term now comes up is finger agnosia. At this particular junction, I am just putting a couple of marks here to say that these 4 features that I've just taught you at the moment, the names are acalculia, agraphia, left-right disorientation, and finger agnosia. They are features or damage to the dominant parietal lobe, and this manifestation is written in MCQs as Gerstmann syndrome. That also tells you the fact that he can put this or ask you as all except MCQ, and he will say which of the following is not a feature. The word is not a feature of Gerstmann syndrome. Then your answer will be what I'm writing at the moment, that is speech can also be affected. So it would be global aphasia. Why I am saying global is because the Wernicke's area and the Broca's area both are supplied by the left middle cerebral artery by superior division, inferior division. Since the main trunk of the left middle cerebral artery is gone, therefore both understanding as well as the expression of speech and the fluency component is hampered. So therefore there would be a global aphasia developing in a patient. The learning for us is that there are total of 5 manifestations that I have written for dominant parietal lobe damage. Out of these 5, 4 that are put with a star mark are features of Gerstmann syndrome. I repeat the fact once again. All that are written here are features of dominant parietal lobe damage, but only the ones with a star mark are features of Gerstmann syndrome. And therefore, I have tried to solve a question before you which begins by saying the except word, and that would be global aphasia is not a feature. Now, let's move on. I will now be speaking regarding what is gonna happen if in a person non-dominant parietal lobe is damaged. I repeat the fact once again. I'm going to explain to you regarding what is going to happen in a person in whom the non-dominant parietal lobe is hampered. Non-dominant parietal lobe is supplied in a right-handed individual by right middle cerebral artery. So I'm just putting a line over this to say that, let me say the clot has gone in the right MCA. So we will here study couple of manifestations which are very, very characteristic to understand non-dominant parietal lobe damage. Before I actually, write those manifestations here, let me just give you a short explanation so you can just keep your pen down and listen to what I'm doing. Let me draw a triangle here before you, another triangle here before you, and then I have drawn another shape that is a star. You see, I don't need to actually tell you that it is a triangle or an inverted triangle or this is a star, or I can just draw these geometrical shapes before you and say, okay, doctor, quickly draw them in your copy. Obviously, you can look at them without me having to tell you what shape it is. And why you can do this is because your dominant parietal lobe has what we technically called as visuospatial skills that you can look, you can understand, and then you can draw. I repeat the fact once again, you can look, you can understand. Obviously, occipital lobe is for vision. So you can see something, you can understand the meaning of it, and you can draw that also. Let me do this once again. Suppose if I draw a clock before you like this, like I put on time also, right? In fact, I'll be demonstrating this before my patient, or I'll just demonstrate any random time that comes to my mind. Like I've shown 9 o'clock in this watch at the moment, and I'm asking my patient, okay, sir, this pen, please draw it. You will notice that a person who's having lack of visuospatial skills might actually understanding partially that you are trying to ask him to draw a clock, but there is a possibility that instead of putting the hours like I have, all the 12 hours per se, he might actually put all the numbers on one side and he might actually draw only one needle and not the complete set. You are noticing that half of the image is missing. The impression that most guys get when I draw this diagram is hemi-neglect. But no guys, I'm not drawing or highlighting a hemi-neglect at the moment. I'll teach you the meaning of the word hemi-neglect also. At the moment, what I'm doing before you is a simple test which is called as clock face test. Why do you do a clock face test? It will help in testing two things. One is the perception, because you see, if you are to draw a clock per se, you need to understand what I'm saying. That's first. And once you have the perception, then you also need to have visuospatial skills that you can look and you can draw and replicate a diagram. In this case, he has drawn only half a diagram or a partial of a diagram. All the manifestations that I've highlighted here before you, one that I put a tick mark here, that is a clock face test which has been drawn in a wrong fashion by the patient, or a person is not able to draw these geometrical shapes or draws them incorrectly, is technically called as constructional apraxia. I will be writing this word in the previous slide as well so that we can see the manifestations of dominant and non-dominant parietal lobe in a single slide. But at the moment, I want to solve an MCQ for you that was asked saying clock face test is done for. A lot of guys casually answered hemi-neglect. Yeah, I'll teach you hemi-neglect component. It can tell you partially about hemi-neglect also, but the first answer for clock face test is not hemi-neglect, guys. It is constructional apraxia. Meaning of the word constructional apraxia is loss of visuospatial skills by a person. He is not going to understand these geometrical shapes. Now let me say one more thing before you, like if I place rice before you or noodles, let me say good fried chicken rice, or if you're a vegetarian, a veg fried rice before you, you might be eating from the left side of the plate, right side of the plate. If you're sharing it with your friend, like if your friend is eating from the right side of the plate, you might actually eat it from the left hand side, right? My point is that if a person of stroke, you are putting a plate before him which is containing rice, noodles, whatever, and he's trying to eat with the help of a spoon, you will notice that he might be eating only from half side of the plate. For him, that remaining half side of the plate is non-existent. It is not that he's blind. It's not that he cannot see that part of the plate. He can see it, but he's not realizing that there is food there and he needs to understand. So what I've highlighted now before you is hemi-neglect. Let me give you a second example. There is a patient who suffered from stroke, and you are noticing, or his son and daughter is saying that, sir, when my father tries to shave, like you have put him on a physiotherapy regimen now, he has recovered slightly, and you have put him on a physiotherapy regimen, and you are encouraging this stroke patient who suffered from these manifestations, let me say 15 days back, that, sir, why don't you try and shave by yourself? You will notice he will shave on only one side. His son is saying, sir, my father shaves only on one side. He does not shave across both sides of the face. That is again hemi-neglect. So basically hemi-neglect would mean visual inattention. Like there's rice in the plate. There's a full rice of plate. He's eating only from one side of it. Or he's shaving on only one side of the face. That's the word hemi-neglect per se. So I'll just go back in my previous slide and now in a single slide squeeze in the data before you. I want you to remember three features for non-dominant parietal lobe damage. The first and the foremost is that one of the important function of non-dominant parietal lobe is that it helps us to see, understand, and then draw geometrical shapes. If this is lost, then the technical term that we use for it is called as constructional apraxia. In the exam, this constructional word will usually not be given. I'll tell you the reason for that also in the subsequent part of the discussion. If he just says the word apraxia, the thought process of yours for the exam would be that this is a feature of non-dominant parietal lobe damage. Another manifestation that I want you to remember specifically for this patient, as I highlighted before you, is called as hemi-neglect. Now, when I say or when I highlight about hemi-neglect, I can just say the fact that if he's eating only from half side of the face or if he's shaving only half side of the face per se, it will not affect too much the quality of life, because you see his son and daughter or primary caregiver can feed him from the remaining part of the plate. If he's shaving only half side of the face, his daughter or son can shave it for their dad, right? So it's not going to affect quality of life. And you see the question in the exam was, which manifestation of stroke usually does not require treatment? Two close options were spasticity and hemi-neglect. You see, spasticity, hypertonia causes cramps. Spasticity contributes to a person having difficulty in ambulation. He can have incapacitation, in fact, and you can be using baclofen or other centrally acting agents to reduce the spasticity component. But when it comes to hemi-neglect, I can just say that if somebody cannot eat from half side of the plate, his primary caregiver can feed him from that particular side. It's not that he's going to end up with malnutrition because of that. So I would like to highlight the fact that hemi-neglect usually does not require treatment. We can give treatment for hemi-neglect. I'm not saying that don't treat it. You can treat it. You definitely have treatment in the form of, now listen to me carefully, we do have prism glasses, we do have hemispatial glasses available, we even have eye patching that is being done for treatment of hemi-neglect. So treatment is possible. But what I'm saying is, between hemi-neglect and spasticity, one feature that even if you don't treat will at least not cause grave discomfort to the patient, or at least will hamper with the quality of life, is spasticity needs treatment. Hemi-neglect usually does not require treatment, but at least it's not going to cause immediate mortality in a person. For the seventh manifestation, again a very peculiar one, I want you to remember the term anosognosia. I have used this term even in my description of Alzheimer's disease, because Alzheimer's disease causes cortical atrophy and again can contribute to damage to non-dominant parietal lobe. I mean, there's a cortical atrophy, right, of non-dominant parietal lobe, so anosognosia will occur. Now, what you mean by the word anosognosia is that there is a neurological deficit, but he will not be bothered about it. So, inability to appreciate. In fact, you see, anosognosia means that this person is not bothered about the fact that he cannot use half of his arm, or let me say half side of the body. Let me put it like this. You see, suppose my right hand stops working. Whole day I'll be thinking about this only. Man, my hand is not working. Why did this happen to me? Why did it not happen to my relatives? I must have done some sins in my past life. I would have done some sins in my this life. I mean, that's the normal thought process of somebody, no? Like if you are, even if you're not religious, you might think, I would have done something wrong. That is why God has punished me with such a curse that my hand is not moving. But in this guy, blissfully, I'm saying blissfully, the person will be unaware of the deficit that he is having. So inability, like in Alzheimer's disease, they are forgetful of everything, no? But he's not bothered by it, that, oh, I don't remember my home address, I don't remember my mobile phone number, or I don't know how to log into my social media. So inability to appreciate the severity of the disease per se, inability to appreciate the severity of whatever is the deficit. It could be motor deficit as I highlighted, or it could be cognition defect like in Alzheimer's disease per se. So patient, I would say, is blissfully unaware of the problems that he's having. You can see that we can now divide this discussion artificially into two parts: dominant parietal lobe and non-dominant parietal lobe damage. There are 7 points that I want you to remember for parietal lobe damage, which are manifestations that will come up once I start talking about middle cerebral artery stroke. But at the moment, you know what are the terms that I'll be using. A lot of them will be beginning with A's. acalculia, agraphia. If you read these terms written in a question, it immediately tells you which blood vessel is affected, left MCA. If you read about apraxia of the constructional variety, you read about anosognosia, you read about heavy neglect, immediately know which blood vessel is affected in the patient, right middle cerebral artery. So the objective of this discussion is now coming clear to you that we are trying to go in for what is called as stroke localization, because by looking at the manifestations of a person, you can actually pinpoint which blood vessel is involved. I don't need a radiologist to tell me that, okay, after a MRI, we will tell you which blood vessel is blocked. By looking at the clinical manifestations, I can definitely do a localization of which blood vessel has been affected in this patient, unfortunately. I shall now be explaining to you regarding manifestations of what's going to happen in an individual whose blood supply to the temporal lobe is affected. You see where I've written the word alphabet T per se, that is standing for temporal lobe. Deep inside this area is going to be the hippocampus. Hippocampus is the seat for short-term memory. Like if I ask you per se, doctor, what did you eat for your breakfast today morning, or what did you eat for your dinner last night? You obviously can recall that information. So hippocampus is storing primarily short-term memory. This is itself a general question, that where would you be having storage of long-term memory? Then it's going to be neocortex. Do remember that in Alzheimer's disease, both the areas would be hampered. So in Alzheimer's disease, you would be having a combination of both a loss of short-term as well as long-term memory. But for this particular case that I'm discussing, I am highlighting that because the temporal lobe is the one that is primarily affected, so short-term memory would be lost. In fact, I want to give an example here of a Amir Khan movie by the name of Ghajini. In that movie per se, he was hit on the head by an iron rod by the villain, and subsequent to that, he was having manifestations of loss of short-term memory. So the movie was all about how somebody who cannot remember what happened couple of hours back is gonna go about his life. So you would have seen Amir Khan, using those stick-on pads and writing everything on the walls, etc., just to recall whatever is happening in the previous few hours. Such a manifestation, a peculiar one, is called as antegrade amnesia, and would be the starting point in lot of questions which are gonna talk about damage to the temporal lobe due to stroke. The second manifestation I can explain like this. You meet so many people in your lives, you may not remember everybody's name per se, but you can still remember people by face. You see, suppose you are at the airport, suppose you are at a railway station, and you saw somebody who was with you in your school in class 10th. You may not remember that person's name immediately because it's been so many years. You passed your class 10th, you are in a medical college, that guy could be maybe into engineering, but the moment you see that guy's face, you remember, okay, he was with me in the same school or in the same section or in the same class. So we tend to remember faces as well. In this case, this memory of faces would be lost, and this that I'm writing before you is itself an MCQ. The question in the exam said, what is prosopagnosia? Prosopagnosia would mean impairment of memory of faces. I mean, we tend to meet so many people in our life. We cannot remember everybody by name, but we still can remember people by faces. If they ask you what is the site of lesion seen with respect to prosopagnosia, so I would like to highlight that this is not pure temporal lobe. Actually, the damage is occurring in the connections between the occipital as well as the temporal lobe. Please appreciate that if you have to, see somebody's face, first you need to have vision, and vision actually relays into the occipital lobe. So it's actually the connection between the occipital lobe and the temporal lobe that is hampered in this case, and that results in this manifestation called as prosopagnosia. So there's a possibility that in some books or some notes, you might actually read this manifestation written in occipital lobe damage. I said it is the connection between the two that is snapped in this case, that the person can see, but he cannot remember that, okay, this person was my classmate, or this guy is my, or this family member of mine. I mean, he will not be able to identify his family member. The third manifestation that will be encountered in this patient would be called as complex hallucinations, and they initially might sound funny to you or irritating in fact, but later on you will realize the distress that it is causing to this particular patient. Like I'm describing a patient today who has had damage to the temporal lobe, and his complaints are that he can smell rotten fish in the ward. You see, in the hospital ward, there would be smell of antiseptic, or let me say, if there's no air conditioning in the ward in a hot Indian summer, it would be all sweaty and slimy, and it's gonna be bad smelling. But in this particular case, he's pointing out to the fact that I can smell a dead rat somewhere, or I can smell a rotten fish somewhere. Though obviously that's a perception of this guy; it's not happening anywhere. This person might actually be complaining that the hospital food is poisoned. Everybody else is eating the same food, nobody has complained. But for this patient, there's a constant metallic taste in the mouth, which is making him complain to you regarding the quality of the hospital food. Similarly, in the dead of the night when everybody else is sleeping, you see, in a hospital, there would obviously be the sounds of the monitors that are going to be used to monitor these patients. But in this guy, he can maybe hear music in the background. The fourth manifestation and the fifth manifestation are again a little peculiar ones. They're called as deja vu and jamai vu. Now, deja vu would mean undue familiarity, like you have introduced yourself to a patient of stroke. You have said that, okay, I'm the intern on duty and I'm gonna be taking care of you, and this patient is behaving as if he knows you for a very long period. That is undue familiarity. In contrast, when it comes to Jamaivu, it will be opposite to normal. That would be unfamiliarity, like he's looking at his wife of 20 years and he's behaving like, who the hell are you? So there's a difference between obviously the two terms. Deja vu is undue familiarity, and in Jamaivu it is unfamiliarity. These are the manifestations which are seen in temporal lobe damage. I would especially like you to remember terms like antegrade amnesia, prosopagnosia, and complex hallucinations for the manifestations of damage to this area. Now I will introduce two multiple choice questions before we go forward and discuss regarding what is going to happen to somebody if the frontal lobe is affected. The two MCQs that were asked in the exam were using the vocabulary like pure word deafness and pure word blindness. Let me explain this to you. When I say the word pure word deafness, I don't mean that the person is having any problem with his ear, outer ear, middle ear, inner ear, eighth nerve, everything is normal. The problem is in the reception area. The reception area would be the temporal lobe again. The superior temporal gyrus in this guy has been hampered due to maybe blockage of the left middle cerebral artery. So the question simply said, what is the site of lesion in a person having pure word deafness? Your answer would be superior temporal gyrus, because that would be where we are talking about Wernicke's area or association areas for the Wernicke's area. Wernicke's area per se is for understanding, it is for comprehension which has been hampered. The next MCQ, however, said pure word blindness. Now you can understand that this particular guy, he's having no problems with his ocular apparatus. There's no problem with the optic nerve. But when you write some words, those words he is not able to appreciate. They have asked what is the site of lesion where pure word blindness would occur. So the site of lesion would be answered as left occipital lobe. I have already highlighted that occipital lobe per se is the site where all the vision would be integrated. In some MCQs, because it will be easy for you, because everybody knows that occipital lobe is related to vision interpretation only. So you might notice that he may not have occipital lobe in the options, and you will then notice the term given splenium. Splenium is the posteriormost part of the corpus callosum. Corpus callosum is what integrates the left and the right cerebral hemispheres per se. But these are two questions where they had asked in the exam, and specifically they said what is the site of lesion for both of these conditions. So you can just remember it from the perspective that vision is going to be integrated in the occipital lobe and understanding part is related to the temporal lobe. So then you can definitely crack these questions. We will now focus on what is going to happen when the frontal lobe of the brain is damaged, and now we will be having some very dramatic features that will be appearing in the patient. The first and foremost will be marked change in the personality of this individual. In fact, he might actually exhibit traits of antisocial behavior. Like, this is an old man, he had damage to the blood supply of the frontal lobe. Now this guy might actually take off his clothes. He might expose himself to people of opposite gender, that's a sex-related crime, or even people of the same gender while his son and daughter are with him. I mean, his son and daughter are ashamed of the fact that their father was exhibiting this kind of I would say, a shameless behavior. I mean, his son and daughter are very apologetic. They say, sir, I don't know what has really gone wrong with him, that there's a marked change in his personality. Previously, he was like a very kind person. Whenever he used to meet somebody, he used to wish him, greet him, talk nicely, and now he's using abusive words. So whenever you read about aggression, whenever you read about antisocial behavior and personality change, it is definitely a damage to the frontal lobe. And here I can explain these 2 points from another example. I can give example of heavyweight boxer Mike Tyson. Mike Tyson was convicted for rape. He was jailed for it actually, and he never apologized for it. Mike Tyson is now making a comeback in his 50s, if you are aware of, and if you are a sports enthusiast. But Mike Tyson, in the middle of his career, he became very aggressive, uncontrollable, to the level that if you follow one of the bouts of Mike Tyson with the athlete by the name of Evander Holyfield, during that bout, this guy, Mike Tyson, he became so angry that he bit ear. He literally, I mean, with his mouth, right, with his teeth, he bit off the ear of Evander Holyfield. You can just go to YouTube and just type the word Mike Tyson versus Evander Holyfield and just see how bloody the fight was. I mean, that aggression, how did he develop that aggression? That aggression is not that Mike Tyson had that inbuilt aggression. You see, people who are in body contact sports, when punches will come from the front in all through the years of the career of this guy, then there would be definitely microscopic bleeds in the frontal lobe, and these bleeds will keep on accumulating over a couple of years, and that will make these guys become aggressive. So lots of guys into mixed martial arts, lots of guys into boxing actually lose it. They might be arrested for maybe killing or making attempt to kill somebody, or might be committing sex related crimes. That's mainly because the frontal lobe damage is causing them to behave like this. The third manifestation of this person would again make this patient's son and daughter apologize to you that in your consultation room this man has urinated sitting on a chair and it's a mess. You see, the part of the brain that is responsible for control of urinary bladder is called as paracentral lobule. Suppose a person is in a doctor's consultation, or suppose somebody is talking on the cell phone with the international client, then person can postpone going to the bathroom for a few minutes, no? Paracentral lobule affords the control of a urinary bladder to a normal person. Paracentral lobule is present in the frontal lobe, and since it is damaged, the control of the bladder is lost. Therefore, in this person, every few minutes his bladder will contract and he will urinate, causing soiling of the clothes of this person, making your consultation room unhygienic. His son and daughter are asking you, sir, does my dad need a diaper? You see, normally diapers are for children. So to explain to a grown-up man that we are going to put a diaper on you is really going to be difficult, because he's going to be aggressive and he might take it off as well. In fact, sometimes because these patients urinate again and again and again, the relatives will go to the nurse will call up the housekeeping department, and they will have to change the bedsheet of this guy. Now, every half an hour, if the nurse has to do this activity of calling up the housekeeping and getting the bedsheet of this patient changed, your nurse might actually be requesting you, sir, please put a Foley's catheter in this person. Obviously, you won't put it on listening to advice of the nurse, but your nurse can actually say that, no, sir, please put a Foley's catheter in this patient. He's troubling a lot. His relatives are troubling a lot. Every time he soils the bedsheet, they're asking me to come and change it, or asking the housekeeping for changing of the bedsheet. How do we frequently do that? It's a logistic issue. Nurse needs to work, no, not call up the housekeeping every time and then ensure a bedsheet of a patient is changed. So if you try to put a Foley's catheter in this guy, first he might be very hostile and he may not let you do it. But suppose you are able to restrain him to the hospital bed and you are able to put a Foley's catheter. Once you put the Foley's, gone out of the room, taken off your gloves, then there's a possibility that this guy might actually hold his Foley's catheter and pull it out. This might cause, he may not be able to pull it out, but at least he'll try to pull it out. This can cause urethral rupture. This can cause blood everywhere from his private parts. So these patients will not be affected by it. Or I can give another example. You have put a IV cannula in this guy for some intervention. Once the IV cannula is in place, you have put leucoplast, etc., and you went out of the room, and this guy will take out his cannula, keep it on the side. There's blood everywhere. His daughter is freaking out seeing all the blood on the hospital sheet. That would look obviously nasty. But for him, that all that blood coming out from the site where you have put the cannula, he's not affected by it. So another manifestation that I've highlighted in these patients is apathy, which would mean that this person is not going to be bothered by the fact that there's blood, or he might try to actually pull out his Foley's catheter. Very characteristic. The fifth manifestation I usually find people getting wrong and mistaking it with motor aphasia. Please appreciate, if Broca's area is damaged, Broca's area is for expression of speech, Broca's area is for fluency, Broca's area is for grammar, syntax. If Broca's area is damaged, we call it motor aphasia. But at that point, you see, the blood vessel that should be blocked is left middle cerebral artery. But look at the word that I wrote here. I did not write the word motor aphasia. I wrote abulia. Meaning of the word abulia is lack of desire to speak. That means when he wants to speak, he will speak. Like his son and daughter is saying that, doctor, before you came into the room, this guy was a chatterbox. My dad was continuously talking. Oh, I have this complaint, let the doctor come. I will tell all these list of complaints to the doctor. But now when the doctor is inside the room, he's totally silent. And his son is saying, sir, dad, what happened? His son will say, sir, before you came, he was continuously talking, but now he's suddenly silent. And even if you ask him to speak, he may not speak because there's a lack of desire to speak. So there's a difference between the word motor aphasia, where a person genuinely cannot speak because expression is affected. In this case, it is lack of desire to speak. So both terms are grossly different. The sixth manifestation is again very characteristic, and most of the time I usually don't find people making mistake with point number 6, that is primitive reflexes that we see in newborn babies is gonna be present in an adult person. Now how is that possible? You see, there are so many primitive reflexes, all of them are gonna disappear by a particular age group. Why primitive reflexes disappear is because of the dominance of the frontal lobe. In this case, because frontal lobe is injured, the dominance is gone, and once the dominance is gone, the primitive reflexes will develop in this adult person. Let's look at few examples here. One of the primitive reflex that you always find in newborn babies is grasp reflex. A baby will always keep its hands tightly clenched in the form of a fist. This grasp reflex, you are aware from pediatrics, will persist for a particular age group and then disappears, and you very well know that grasp reflex will persist up to 4 months of age. Then the hands of the baby will relax, and then they can be unidextrous approach, bidextrous approach, etc. But the message is that why the reflex disappears by 4 months of age is because of the dominance of the frontal lobe, and if the dominance is gone due to injury, then the reflex will develop or will become positive even in an adult man as well. Let's take up another example. Instead of a grasp reflex, I can give example of a rooting reflex. Rooting reflex looks very cute, you know that, no? In a newborn baby, if you have taken a delivery and then you touch the cheeks of a baby, he's going to turn his head towards that stimulus. So rooting reflex is that the baby is trying to seek the breast. It persists up to a particular age, that is 1 month. After that, it disappears. But imagine adult patient, if you are stroking the side of the face of a patient of frontal lobe damage, he will turn his head towards that stimulus. So rooting reflex would be present in adult patient. Why? Because the dominance of the frontal lobe is gone. Now here the examiner would also like to play a trick on you, though since I warned you, you would not be affected by it. You see, Moro's reflex is always taught in pediatrics and it persists till approximately 6 months of age. I want you to remember that Moro's reflex, once it's gonna disappear at 6 months of age, it never, mark my words there guys, Moro's reflex, once it will disappear, it will never reappear. That's the point I want you to remember. Moro's reflex, if written plus in an adult patient, that's a deliberate wrong information given by the examiner to actually trick you into the fact, because he knows that primitive reflexes are anyway positive in a frontal lobe damage. The message is all the primitive reflexes that you learn in pediatrics can be written plus or positive in a person of frontal lobe damage, except one, Moro's reflex is never gonna be present. The seventh manifestation of this patient I can explain like this, suppose I have come to your city for a face-to-face class and we have taken a session of 3 hours. Now I say, okay doctor, it's break time. So you would casually get up from your chair, go outside, have tea, coffee, and then chat around with your friends, and then come back after 15-20 minutes and sit in the class once again, waiting for me to resume the class. But suppose I'm taking a class, you sitting across me, and there's an earthquake happening. Would you wait for me to say, please evacuate? I mean, you are simply gonna dump everything and you're gonna run out. Like, let me say the earthquake is on Richter scale 6 point or 7.0 or even 8.0. The whole building is shaking. I mean, you're not gonna wait for me to say, okay, please evacuate the hall. You dump everything and you're gonna rush outside. So what is the basic function of the frontal lobe over and above what we're discussing is that it is also responsible for programming of gait. That is, suppose I say, okay doctor, it is break time, you will casually get up and walk slowly, right? But if it's gonna be earthquake, then you're gonna run. So frontal lobe decides how you are gonna react to a situation. Now, in a person in whom the frontal lobe is damaged, I put it on myself. If my frontal lobe is damaged, and right now when I'm recording this data for you and there's an earthquake happening, I know that there's an earthquake happening, but still I will not be able to make a dash for my life. I will not be able to walk fast, though my brain is telling me, yes, there's an earthquake happening, but I'm not reacting to that situation. It could be a life-threatening situation in a sense that the whole building is shaking. Everybody wants to get out of the building. I'm the only one sitting here only. The manifestation that I want to teach you here is technically called as magnetic gait. It's a very characteristic feature of frontal lobe damage where the programming of gait is defective, that the person is not able to react to a situation. The learning point is whenever you are faced in a life-threatening situation, you will try to walk faster or run or whatever, or at least try to minimize the damage caused to you. But in this case, the body will not be able to react, though he can perceive things. Magnetic gait in lot of multiple choice questions is deliberately written as gait apraxia. Now you understand why I was asking you to remember the word apraxia, because I taught you apraxia a little earlier for patients who are having damage to the non-dominant parietal lobe. But now I'm teaching you the word gait apraxia. Remember guys, there it was constructional apraxia. The visuospatial skills were affected, but here it's gonna be gait apraxia. So this is itself a question. Gait apraxia is seen due to features of answer is frontal lobe damage, and lots of time deliberately he might just put up a blood vessel, ACA, MCA, posterior cerebral artery. Frontal lobe is supplied by anterior cerebral artery. So you will answer gait apraxia is a feature of anterior cerebral artery stroke, whereas constructional apraxia is a feature of MCA territory stroke. At this juncture, I would also like to mention regarding a patient of Parkinsonism. If you see a patient of Parkinsonism walking, you will notice that they will be having very sufficient amount of rigidity in the legs, that they will not be able to bend or flex their knees. It would be as if walking on logs of wood, and you can also hear the soles of the shoes of this guy rubbing against the ground. So people who having Parkinsonism actually walk as if the feet are rubbing against the ground, or you can hear the soles of the shoes of the ground rubbing against the surface. They would be a stoop posture, and when you and me walk, we have an automatic arm swing. But in this case, there is absolutely no automatic arm swing. You can see the partially flexed arms of this individual. What I'm trying to describe before you is called as a fascinating gait. The features of fascinating gait, I'll just reiterate before you. The person will walk with short shuffling steps. You will also notice that when this chap will walk, there's a tendency to fall as well. Like if there's a object in the path of this person, he may not be able to raise his legs over the obstacle. He might actually slam into this and fall also. Postural instability is a feature of Parkinsonism. There is a reduction in the automatic arm swing to the level that the arm swing might be completely absent. And you will also notice stooped posture present in these patients. All these three that I've highlighted before you are features of a very classical feature of Parkinson disease, and is discussed even in Parkinsonism as well. But I just wanted to draw parallels that in fascinating gait, at least is trying to walk. No, fascinating gait is a feature very characteristic with respect to Parkinson disease, whereas when you read the word magnetic gait, it should immediately tell you the damage is in the frontal lobe, the blood vessel affected is anterior cerebral artery. I shall now be explaining to you regarding occipital lobe damage, where the blood vessel that is affected is P2 branch of posterior cerebral artery. In fact, I'll draw these blood vessels before you as well, so that you can have a better orientation regarding the blood supply of the brain. But once this blood vessel is affected, then the first manifestation that will develop in the patient would be related to vision, and you will answer this as visual hallucinations. The second manifestation is again very characteristic and is called as palinopsia. Now let me explain to you what I mean by the word palinopsia. Like at the moment, if I show you this pen and then if I hide this pen, then obviously you can't see the pen. Well, I'm not doing a magic show. All I'm saying is if I show you this pen and then if I hide it, then obviously you can't see. But in a person having occipital lobe damage, if you show him the pen, he can see the pen, but even when you hide it, he can still see the pen. Looks surprising, right? The meaning of the word palinopsia is persistence of an image even when the object has been removed. Like I hid the pen, but the guy can still see the object because his occipital cortex has become slow in appreciating the movement that I basically did. I repeat the fact once again. The meaning of the word palinopsia would be persistence of image even when the object has been removed from the FOV. That would mean the field of vision per se. The third manifestation is again very characteristic. It is called as asimiltagnosia. Well, if you try to use a bit of English here, you will be able to decipher the meaning of it. It basically means simultaneous visual information cannot be processed. Like at the moment, I can show you this pen. Then I can just show any random object to you. You see, if I just say what is this, you can say a pen. If you say this looks like some kind of a connector. But in this person, he can identify a pen, he can identify a connector. But if I show the two objects together, then he will not be able to appreciate it. So the meaning of the word asimiltagnosia is that the simultaneous visual information, like I was showing two objects together, individually he can pick up the object, but simultaneous visual information cannot be processed by the brain, again because the occipital cortex has been hampered in this case. The message, or if you can, in fact most people are able to crack point number 3 by English only, simultagnosia, no? So simultaneous visual information is not processed by the brain, or rather the brain will become relatively slow in processing it. For the fourth manifestation, well, it would be standard homonymous hemianopia developing in a patient. Lots of time in anatomy classes, you might be hearing that in occipital lobe damage, there might be homonymous hemianopia with macular sparing. I agree that that's a slight dispute, but in 20th edition of Harrison, he has mentioned occipital lobe damage results in what I've just written here, that is homonymous hemianopia. So I'll quote Harrison here, the 20th edition. If you want, I can send you a snapshot of that as well. HS would mean homonymous hemianopia in this case, and these are the manifestations once you would be having P2 PCA being blocked. In one of the exams, he actually asked what is going to happen if bilateral distal. You see, P2 PCA. P2 basically means distal only. So he said, what is going to happen to the patient if it's going to be a bilateral distal PCA blockage? Like there are two clots, both went into the distal PCA and are causing a physical obstruction. Then both side occipital cortex is gone. And because both side occipital cortex is gone, the manifestation would be called as cortical blindness. Well, the meaning of the word cortical blindness is that there is definitely a blindness in a patient, but there would be normal pupillary reflexes. The circuit related to pupillary reflex, you very well know, relays by the Edinger-Westphal nucleus in the midbrain. So, per se, the pupillary reflex will not be affected, but at the same time, the person is not able to appreciate the object that you are showing to him. In fact, sometimes it might so happen in cortical blindness that tiny islands of vision might be preserved. You see, per se, when you look at PCA, it will be having subsequent branches. So some of the branches might still be perfused at the moment, or they might be having a collateral supply. So some islands of vision will be preserved. Because of this, lots of time we will notice that in people who are having a distal PCA blockage, mainly the central vision, because central vision can also come from middle cerebral artery. So therefore the central vision might be preserved in the patient, and therefore the word used to describe this central vision, peripheral vision, all called is called as gun barrel vision. Gun barrel vision can be like you are looking into the barrel of a gun of a sniper, like you can just focus on the target, but the peripheral vision is all gone. So gun barrel vision basically implies that central vision is preserved. In fact, as I said, sometimes it might be central vision and maybe some part of peripheral also. So islands of vision is a description that is given in the textbook, and the implication of that is, I'll put it on myself. Suppose my entire visual field went black, but light is coming from some areas. So I'll be very hopeful that okay, maybe one day I might recover. So most patients who are having this gun barrel vision or islands of vision are in denial of blindness, because you see, becoming blind in adult age group is a curse. If my whole visual field went black, I became blind, I am understanding it. But if small islands of vision are present, I'll say, okay, I might recover. I mean, that's a normal thought process of human being. Know that every person is positive about his or her health, that okay, one day I'm gonna recover. So these patients initially might be in denial of the blindness, and he will say, no, I can see some light coming, I'm perfectly fine, I think I'll be fine. So, and when you ask this guy, okay, fine, I understand what you're saying, can you just walk around for me? He will bump into objects, because you see, when I'm walking, I need to see objects around me also, no? If I am having only some tiny islands of vision, I will be able to see in some areas only. The remaining areas are obscured for me, so I might bump into objects, I might bump into people as well. So this description that I just gave you, where a person has become cortically blind but denies the blindness because some islands of vision are still present, is technically called as Anton syndrome. Most of the time, the question that will come on Anton syndrome will ask you which blood vessel is blocked. So that's the priority that you need to understand. And then, why I have described it is because the query of most doctors is, sir, on one hand you are saying cortical blindness, then how can you see? The message is that there could be some blood supply from the middle cerebral artery, especially for the central vision, and since all blood supply will not be extinguished simultaneously, so some islands of vision if are present, then a person as a normal human being will be positive about his health. He will think that okay, I might recover, and that is why he's initially having this denial. I mean, anybody, when you tell somebody, okay, you are having coronary artery blockage, 3 coronary arteries are blocked, he'll say, no, sir, this report is wrong. That's the thought process of every human being. When you tell bad news to somebody, the first thought process is, it can't be true. This is too bad to be true to be happening to me. And the same thing is what I've reflected here. So the message is Anton syndrome is bilateral PCA blockage, and there would be a gun barrel vision present in the patient. Those are 3 aspects that I would like you to remember specifically. Now I will try to implement this information. What I have just taught you is damage to various parts of the brain, that is frontal, parietal, temporal and occipital. And now I'm showing the brain from the lateral aspect. This is the motor cortex, which is also called as area 4 or is also called as motor homunculus, and all our body muscles are represented here. Obviously we have a left and a right cerebral cortex, but here I will just try to represent our body the way it is represented in the motor cortex, with the feet being higher than is the upper limb, the trunk, and the face. Now this is a two-dimensional diagram. So what I'm doing is that one side of my face, like let me say my right side of the face is controlled by my left, no? So I'm just shading one side to just highlight the same thing because it's a two-dimensional diagram. I'm trying to say that my right face, right arm, right leg is controlled by left and vice versa. So that shading just represents that there are two sides of the cerebral cortex and there's obviously a crossover. Now the line that I'm putting like this is highlighting that this entire area where the black dots are present is supplied by the anterior cerebral artery, and a big chunk of frontal lobe is also supplied by anterior cerebral artery. The implication of knowing this information is that, suppose I'll take it on myself, if my left anterior cerebral artery is blocked, then I will develop paralysis of my right leg, not of my arm, not of my face, not of my trunk, but mainly of my leg per se. If my both anterior cerebral arteries are blocked, then my both legs will undergo paralysis, but my face and legs will still be spared. But along with that, because frontal lobe will also be afflicted, so there might be change in my personality, aggressive behavior, antisocial behavior, abulia will be the features that is occurring. What we're trying to do here is stroke localization per se. You can see that the area where the black dots are put, that is all supplied by the frontal lobe per se. Frontal lobe included is supplied by the anterior cerebral artery. So the blockage of this will result in varied manifestations. In fact, in a multiple choice question, if you read a question that begins by saying that a person has had a sudden onset spastic monoplegia, like he was sitting watching television and looking at the launch of COVID-19 vaccines, and when it's going to be rolled out in India, and suddenly he felt that his right leg is not working or left leg is not working, or unfortunately both legs are not working, and he's wondering to himself, am I going to be wheelchair bound for whole of my life? Spastic paraplegia is a feature that you encounter with anterior cerebral artery blockage. Then the person might even develop abulia, that is different from motor aphasia. Why? Because Broca's area that I'm highlighting at the moment, this is Broca's area, this is Wernicke's area. Broca's area, which I have written with alphabet B, is not supplied by the anterior cerebral artery. The Broca's area is supplied by the superior division of the middle cerebral artery. So I'm not talking about motor aphasia, I'm talking about lack of desire to speak. Similarly, in this person, there might even be development of personality changes and urinary incontinence. So usually he's going to give you a case like this, which I've written, and he will say which blood vessel looks to be blocked in this person. The answer would be ACA. To trouble you further, he might even put it options as A1 branch, A2 branch. So when I draw the diagram of the brain blood vessels, though you have read that in anatomy, it will make more sense to you. But at the moment, I just want you to remember this information. I'll prove it to you in about 5 minutes from now that why is it A2 branch of ACA that I'm saying is affected in this case. If A1 is blocked, usually stroke manifestations are not seen because blood supply can come from contralateral side. So please be patient for 5 minutes, and when I draw the diagram, I'll come to this point once again. I'll prove to you why A1 branch of ACA blockage may not cause stroke-like manifestations. Moving ahead, if in a person middle cerebral artery is blocked, then you can very well see this entire area except for the area that I've enumerated, that is the occipital lobe, which is supplied by the P2 branch of posterior cerebral artery. The remaining entire area in white that is highlighted, including Broca's area, Wernicke's area, including the connection between the two, that is called as arcuus fasciculus, that is responsible for repetition. All the area in white is supplied by middle cerebral artery, and God forbid if in somebody the middle cerebral artery, let me say of the left side, is affected, then there would be a classical manifestation of contralateral face weakness. In fact, that was the case that I was talking about. This person, he's a banker. He's taking a sales meeting, and suddenly there is a sudden onset face weakness. There's sagging of muscles on one side of the face, and juniors in the meeting, they're giggling to each other. See how the boss is looking, because they're sagging of muscles on one side. And then there's also an arm weakness. Earlier, just I'll say 2 minutes before in the meeting, this senior manager in a multinational company, he was actually giving a PowerPoint presentation. He was gesticulating his left arm, right arm. He was like, when we talk, our arms move subconsciously. So he was gesticulating, he was moving his arms, and now suddenly one of the arm, the power is gone. There is a sudden onset arm weakness manifestations that has developed in this individual. Along with this, visual issues can also be present in the form of homonymous hemianopia. Well, why homonymous hemianopia? Because when you study the entire circuit related to the occipital lobe, it starts anteriorly, from the optic nerve, the optic chiasma, the optic tract, and then subsequently onwards optic radiation, and then the occipital cortex. So if there's a damage subsequently to the optic tract, which is going to be coursing through the area where the middle cerebral artery is traveling, there can be definitely a homonymous hemianopia developing in the patient. Lots of time in patients of middle cerebral artery stroke, you will also have this feature called as gaze preference. Though this is not very helpful, but I just wanna give you a hack here that in patients who are having cortical stroke, the patient looks at the lesion. Like suppose, for example, left middle cerebral artery will be blocked in the person, then both eyes of the patient will be looking towards left side only. So looks at the lesion in cases of cortical stroke, but when it's gonna be brainstem stroke, in brainstem stroke, the patient looks away from the lesion. Now, obviously, both eyes are moving away in one particular direction. You don't know now whether it is cortical or brainstem stroke. You obviously will have to see other features also. Like in brainstem stroke, there will always be granular palsies. But granular palsies would not be seen in what we are discussing at the moment because we are discussing cortical stroke per se. So if granular palsies are coexistent and eyes are showing a deviation to one side, that's suggestive of brainstem stroke. If there are no granular palsies and the eyes are looking to one side, it is suggestive of a cortical stroke in a patient. Over and above this, I've also taught you that if it is the left middle cerebral artery that will be blocked, then the blood supply, both the Wernicke's and the Broca's area would be gauze. So there would be a global aphasia developing in a person. If it is right middle cerebral artery that is affected, then there would be constructional apraxia, hemi-neglect, and anosoagnosia developing in a patient. And God forbid, both are affected, then both manifestations will occur in the patient. The objective is to go in for stroke localization. I mean, by reading the clinical manifestations in the question, you definitely can pick up which part of the brain per se is affected. In case it is the P2 branch or posterior cerebral artery, I personally feel this is one of the easiest ones for you to identify because there would be visual hallucinations, there will be palinopsia, simultagnosia, and the characteristic features of visual deficits that will develop in the patient. Or if he writes the word cortical blindness, I mean, the work is done for you. You know that the blood vessel involved is posterior cerebral artery. In contrast, if he talks about damage to or the blockage of the lenticulostriate artery. Now, lenticulostriate artery is one of the branches of the middle cerebral artery that will mainly supply the internal capsule. Internal capsule is the area from where the corticospinal pathway is growing. When I say internal capsule, it will be separating the thalamus from the lenticular nucleus. I can just draw a diagram here. Let me say this is the representation of the thalamus. Medial to this will be the third ventricle of the brain. Then I have shown here is the lenticular nucleus. This is gonna be the putamen, alphabet P. This that I've highlighted before you is globus pallidus interna, and separating the two like this that I've shown is the internal capsule, and internal capsule is the area from which the corticospinal pathway is traveling. This is the genu, and now gonna show the face of the individual, the legs per se. I just want to highlight that if there's damage to the blood supply of the internal capsule, then because the corticospinal pathway that controls the muscles of the face, controls the muscles of the arm and the leg are affected, therefore there would be neurological feature in the form of hemiplegia developing in a patient. The message is if lenticulostriate artery or even its smaller branches are blocked, then the term used in multiple choice question can be lacunar stroke. I want you to understand that whenever lacunar stroke is written per se, it means it is the blockage of the ultra small blood vessels like lenticulostriate and smaller. In fact, lot of MCQs will say lacunar stroke occurs due to, then your answer will be given as lipohyalinosis. Do not use the word atherosclerosis. Use a milder version of it, that is lipohyalinosis. This lipohyalinosis mainly affects the smaller blood vessels of the brain, that is like perforator branches. So lacunar stroke mainly gonna be involving the small blood vessels. The risk factors for lacunar stroke are gonna be same as that for development of stroke or coronary artery disease. So hypertension, diabetes mellitus, cigarette smoking, the standard information that I have discussed in cardiology, the same risk factors are responsible for stroke and the same are responsible for lacunar stroke also. The only thing is it is the smaller branches that are getting involved. Now per se, if he highlights this word internal capsule is affected in an individual that I marked in red before you, then because it is going to be only the corticospinal pathway damage, therefore there will be only hemiplegia related to face, arm and the leg. The question will use the word pure motor stroke or pure sensory stroke. Pure sensory because you can see thalamus is adjacent to this. So whenever you read about pure motor or pure sensory stroke, what you understand by the word pure motor and pure sensory is, guys, that there's going to be no use of terminology like aphasia, apraxia, abulia. Those are features of cortical stroke. I mean, how do you differentiate whether a person is having a cortical stroke or whether a person is having a capsular stroke is what I'm trying to teach you here. If it is going to be cortical stroke, then the question will always have these terminologies beginning with alphabet A, like acalculia, agnosia, anosoagnosia being mentioned per se. On the other hand, if he just talks about hemiplegia, he just says that in a person, it is the face paralysis, arm paralysis, and then the leg paralysis occurring in a patient. While in cortical stroke, no, I was making a distinction, like I was saying, patient having only leg paralysis, only face and arm paralysis. Here I'm saying paralysis of the face, arm, and the leg subsequently, right? Only manifestations of hemiplegia are developing, or hemianesthesia are developing. Hemiplegia, hemianesthesia, but none of the terminologies that are discussed with alphabet A are given in a question. That basically means the lesion is at the level of the internal capsule per se. And then I can also say that if perforators are involved, then an additional terminology that I've highlighted is called as lacunar stroke. I repeat the facts once again, guys. When it comes to cortical stroke, all the features with alphabet A will be given. If he specifies the word patient is not having any of the features of A and he just says pure motor stroke, pure sensory stroke, or just gives you features of hemiplegia plus minus hemianesthesia, then it's going to be suggestive of internal capsule getting involved, where face, arm, and leg weakness can be described, but none of the A features present. If he talks about hemiplegia with cranial palsies, it's going to be brainstem stroke in a person, and there's also possibility that only perforators are getting involved. No, smaller blood vessels that I'm talking about is even smaller than lenticulostriate, perforators getting affected, then it would be called as lacunar stroke per se. So these are some terminologies that I want you to understand at the moment, and now I'll be describing the blood supply of the brain before you so that you are better oriented to all these aspects. I shall now be describing regarding the blood supply of the brain, and I would suggest you to hand draw this diagram with me. One of the biggest blood vessels that I've highlighted here happens to be the internal carotid artery, which will give rise to MCA, middle cerebral artery. The details of middle cerebral artery is what I've highlighted in an animation part as well in the starting of the neurology section, so you can go through that. And now going anteriorly is the ACA, anterior cerebral artery. This blood vessel that I'm joining right now to the contralateral anterior cerebral artery in a wavy fashion is the anterior communicating artery per se. This is one of the important sites where the berry aneurysm would be present. In fact, the area where I've just put the star mark, that is the junction of the anterior communicating artery with the anterior cerebral artery. This is the commonest location of berry aneurysm. Though berry aneurysm can rupture at any site, but the common site where it will rupture will be posteriorly located at the basilar artery. But if he just says, doesn't talk about rupture, just says what is the common site of berry aneurysm per se, then your answer would be given as junction of anterior communicating with the anterior cerebral artery. Now I'm coming to the segments here, that is A1 segment, and then the distal part is called as the A2 segment. What I want to say, and I don't want you to at the moment do any shading, I'm just doing it for hypothetical reasons because it will spoil your diagram. You see, I'm just introducing a thrombus in the A1 segment on one side. You can see the fact that the moment I will draw a thrombus here, there is a possibility that the blood can supply or blood can flow across this particular communicating artery and can still travel to the A2 segment. You can see very well that the communicating artery will act like a bridge. It will still supply the A2 segment and therefore neurological manifestations will not be seen. Vice versa, if I show the A1 segment of the other artery getting blocked, then the blood can come from the opposite side. As a result of it, neurological features are usually not seen, or even if they appear, they might disappear very soon because the blood supply can occur from the contralateral side via the communicating artery. So A1 is well tolerated. A1 blockage is well tolerated, but A2 blockage, you can see there is no collateral circulation coming up. So as a result of it, the neurological manifestations will develop. This explains the fact that why in the earlier part of the discussion I was highlighting the fact that A2 blockage will cause neurological manifestations, but A1 will be well tolerated. I can draw one more blood vessel here, which is by the name of anterior choroidal artery, which is fairly thin. This anterior choroidal artery again is if involved by any thrombus or embolus, then the stroke is well tolerated. In fact, I'll give you the reason for this also. Let's just put a name to these blood vessels, because lots of time in the exam, they might actually give you a brain angiography report and ask you to mark these blood vessels as well. Now, the reason why I said anterior choroidal artery stroke is well tolerated is because of collateral circulation. I mean, the area that anterior choroidal artery will supply, that area will also be supplied by lots of other blood vessels which are present here. Like for example, area supplied by middle cerebral artery, and even with PCOM basically means posterior communicating artery that I'll be drawing before you. So two strokes that can be well tolerated and may not show very significant neurological deficit are: part number 1, A1 branch of ACA blockage, second anterior choroidal artery. Both are beginning with A, so I'll repeat that again. A1 segment of anterior cerebral artery stroke and anterior communicating artery stroke might be well tolerated because of the collateral circulation that is present. However, we now move a little posteriorly. You see, running up in our neck through the foramen transversarium is the vertebral artery. This vertebral artery will then unite together to form a basilar artery, and basilar artery will then branch into what we call as the PCA, the posterior cerebral, which will have a P1 segment and the P2 segment. What you need to remember right now is that the P1 segment is the one that will be supplying the midbrain, whereas P2 segment will be going posteriorly, so it will be supplying the occipital cortex. If the P1 segment is blocked, then person will develop midbrain stroke. If P2 is blocked, it is occipital cortex that would be damaged, that can cause visual hallucinations. And if bilateral P2 PC is blocked, then I described Anton syndrome to you as well. I'm now gonna draw a wavy blood vessel here, which I'll write as PCOM, that basically means posterior communicating artery. In the exam, they actually put an arrow on this blood vessel and they said, which blood vessel is this? You would be surprised to know that under a pressure cooker situation, lot of guys actually marked this as a posterior communicating artery. You can very well see posterior communicating is very, very small. In fact, one of the guys who did a blunder, he actually, when he approached me with the question saying, sir, there was an arrow on one of the thickest blood vessels, he himself said, thickest blood vessel. And I said, man, how can you make this mistake? I mean, you are yourself saying, no, thickest blood vessel, and then it can't be communicating artery. It has to be the thickest blood vessel per se would be the internal carotid artery. You see, pressure does a lot of thing to our brain, so we need to actually fine tune our brain to pressure situation. I mean, we are not to get affected by it. We need to become neutral to it. Yeah, till the last question is solved. Like in a cricket match, no, till the last ball is bowled, there can be no result. Similarly, when it comes to the MCQ based exam, till the last MCQ is solved by you by exclusion capability, nothing can be predicted about the result. One of the thickest blood vessels here is internal carotid artery, and the dotted one that I'm now marking here is called as PCOM, that is posterior communicating artery. In fact, this was discussed even with respect to Berry aneurysm. I'll highlight the fact once again. You see the yellow structure that I've shown this particular point of time, it can be taken as a representation of the oculomotor nerve, which is just running adjacent to the posterior communicating artery. Now, the importance of knowing this is that, God forbid, if somebody is having an aneurysm in the posterior communicating artery and it is becoming bigger, you can see it can press on the third nerve. In fact, the question that I've discussed is, what is the cranial nerve that can be compressed by an unruptured Berry aneurysm? Then unruptured Berry aneurysm can actually result in compression of the third nerve that can contribute to ptosis, that can contribute to squint. Even if it will rupture, it will press on the third nerve only. Both in unruptured Berry aneurysm as well as in ruptured Berry aneurysm, it is oculomotor nerve that is involved. A common error that I've seen doctors performing is that for ruptured, they tend to answer as sixth. Agreed, in raised ICP, sixth nerve will anyway be involved. But if unruptured is causing pressure on the third, then when it will rupture, it will again cause pressure. In fact, it will cause more pressure on the third. So both for the MCQ of unruptured and ruptured Berry aneurysm, it is oculomotor nerve that is basically hampered. From this discussion, you can very well see that since I highlighted P1 branch is supplying the midbrain, so this was itself a question that which blood vessel blockage will contribute to midbrain stroke in a patient? Answer is P1 PCA. Another time they changed the question. The question said pontine stroke. In those circumstances, which blood vessel will be affected? So you can just follow the anatomical aspect here. In pontine stroke, the blood vessel just posterior to it, that is the basilar artery, where I put alphabet B, that would be affected in the patient. In contrast, when you go down, medulla per se, medullary stroke, we'll talk about lateral medullary and medial medullary also. But in medullary stroke, the blood vessel that would be involved will be the vertebral artery per se. The learning at the movement is midbrain stroke occurs due to blockage of P1 PCA, basilar artery thrombus contributes to pontine stroke, vertebral artery involvement contributes to medullary stroke. Now I will draw through branches of the vertebral artery, so please be patient and listen to this. One of the branches that I'm highlighting now before you is running relatively laterally. This is called as PICA, posterior inferior cerebellar artery. On the other hand, now I will be drawing medially located blood vessel. This medially located blood vessel is the one that you know from anatomy and is called as anterior spinal artery. Well, what is the importance of studying this at the moment? I mean, this is obviously not an anatomy class. I want to highlight that anterior spinal artery is present medially. So the question in the exam simply said, which blood vessel is impacted in medial medullary syndrome? I will link it up to cranial nerves also subsequently, but at the moment you need to just get the data right. In medial medullary syndrome, the blood vessel affected would be the anterior spinal artery. On the other hand, if he says the word lateral medullary syndrome, now listen to my next words very carefully. in lateral medullary syndrome, if he says which is the blood vessel blocked, your first answer will still be vertebral artery. Your answer will still be vertebral artery. If vertebral artery is not in the options, then only then, mark my words there, if not there, only then the answer would be given as this branch that I've highlighted, that is PICA, posterior inferior cerebellar artery. In fact, when posterior inferior cerebellar artery gets involved, then a hack to actually solve the MCQ is multiple cranial nerve palsy. So I'm writing down the numbers of nerves that are involved. I'll draw the diagram of linkages of blood supply with cranial nerves also. But at the moment, if you get a question in which there's going to be 5th nerve, 7th cranial nerve, 8, 9, 10, 11 nerves involved, it's going to be PICA involvement. But when it comes to anterior spinal artery involvement, guys, then 12th nerve is involved, because 12th nerve originates medially. Hypoglossal nerve originates medially. So the medial blood vessel anterior spinal artery involvement per se will cause 12th nerve palsy. On the other hand, when it comes to PICA, it is 5, 7, 8, 9, 10. If we go up a little more superiorly, and now this will make this diagram a little untidy, but I still want you to hand draw this with me. The blood vessel that I'm drawing at the moment is called as AICA, that is anterior inferior cerebellar artery. This anterior inferior cerebellar artery, whenever is involved, the cranial nerves involved are 7, 8. In fact, I'll just move a little more up. Another branch that I'm now showing is, and you should be able to point out these blood vessels actually. I'll use a finer pen this time just for the ease of marking out this blood vessel that I've highlighted. This blood vessel that is now highlighted is called as superior cerebellar artery. So you can see I've shown two branches at the moment, superior cerebellar and AICA. Both are related to the basilar artery per se. Why that is important is because when it comes to superior cerebellar artery, listen to my words with care, there are two MCQs in stroke topic where Horner syndrome will be given. Horner syndrome is a feature that is seen with blockage of the superior cerebellar artery. Horner syndrome is also seen with involvement of PICA as well. So if you encounter a multiple choice question where along with Horner syndrome multiple cranial nerve palsies 5, 7, 8, 9, 10, 11 is given, it is PICA. If it is gonna be Horner syndrome along with features of, let me say, weakness in the arm or gait ataxia, because cerebellar arteries are the ones that are getting involved. So that is why I said they could be gait ataxia occurring or ipsilateral hypotonia. In fact, the surprising thing is I'm teaching you stroke and saying hypotonia, because if cerebellum is affected, you get hypotonia as a manifestation. This will become more clear to you as we progress, but the learning point for you is Horner syndrome, one you read in respiratory system with Pancoast tumor. Right, lung cancer, atypical location, maybe in the apex or adenocarcinoma, can contribute to compression of the sympathetic chain. But in this case, there's going to be descending sympathetic pathways that are going to be involved. So two MCQs of stroke where Horner syndrome can be expected and asked to you, and has been asked actually, is superior cerebellar artery and PICA. And obviously you can differentiate on the basis of cranial nerve palsies that I've highlighted before at the moment. I would rate this as one of the most important slides that has linkages with anatomy as well. So I would personally suggest you to hand draw this before, and rather, in fact, if you have not hand drawn at the moment, you can just take a snapshot of it and maybe post it somewhere so that you can remember all the aspects that are highlighted. Just to know that you are familiar with circle of Willis, the question in the exam said all blood vessels form circle of Willis except. You know this from anatomy, guys. Which blood vessel does not form circle of Willis? Do I need to give you options? Okay, I'll say options. Anterior cerebral, middle cerebral, anterior communicating, posterior communicating artery. I repeat options again fast. Anterior cerebral, middle cerebral, anterior communicating, posterior communicating. Yes, guys, circle of Willis is not gonna be formed by middle cerebral artery. In fact, this looks casual, but is true. Middle cerebral artery is going laterally, right? It does not constitute the circle of Willis per se, but the communicating arteries definitely constitute the circle of Willis per se. Another importance of knowing this information would be, and I can just write down the data before you so that you can understand. Like suppose you are reading about a patient who has developed sudden onset. I mean, in stroke, everything will be given sudden onset only. So that's implied by default, right? There's a unilateral spastic weakness given in a person. Or instead of weakness, he is also mentioning regarding sensory deficit in the form of hemi-anesthesia. The weakness can be described in any of the following areas. It could be face plus arm. It could be face, arm plus leg. I mean, all the three areas like hemiplegia, hemianesthesia given in a question. I mean, that's one of the features. If you ever read in a question, should definitely prompt you to the fact that person is having stroke. Along with this, there can also be optic tract involvement. So optic tract involvement could be written as homonymous hemianopia, right? You know that from ophthalmology as well. Along with that, there could be higher mental functions or higher cerebral function or I would write the word higher cerebral malfunction present in a patient, all these terms will begin with alphabet A. He can talk about apraxia, that is loss of visuospatial skills. He can talk about, let me say, global aphasia, abulia, all those features that I've highlighted before you. If you encounter the following three features given in a patient, it means the fact that person is having involvement of both anterior cerebral as well as middle cerebral artery. Why anterior cerebral artery? Because legs are also getting involved in a patient, and there is higher cerebral malfunction also, no? So the technical term that will be used for this one is called as total anterior circulation stroke. In fact, that's a Bamford classification that is given. You will say total anterior circulation stroke. In fact, lots of time I cannot write as fast as I can basically speak, so that's why sometimes they can be lagged, so please excuse me for that. The word is, if you read about this term TACS, total anterior circulation stroke in a patient, then to answer this there should be three manifestations given per se. That is in the form of unilateral weakness involving half side of the body, homonymous hemianopia, and higher cerebral malfunction. In some questions, there is a distinct possibility that out of the three features which I have just highlighted before you, only two features might be present in a patient, like point number 1 and point number 2 only may be given. Then you will answer this as partial anterior circulation stroke. These are various classifications which are given in various books and various MCQs of various apps. So I just want you to remember this one of the classifications that we use, though more appropriately we use terms like cortical stroke or a capsular stroke or a brainstem stroke. But in some MCQs, because he has used terms like total anterior circulation, partial anterior circulation, so I just want you to remember the features here. And meaning of the word total anterior circulation stroke is that both ACA and MCA are getting involved. Like there's a thrombus just proximal to the bifurcation, the diagram that I showed, no? This is what I am saying. Like unfortunately, if the thrombus is in this particular area that I have just highlighted or shading before you, then the blood supply of ACA, MCA both would be affected, and therefore the opposite side of the body would get involved, and all the standard features that I highlighted would develop in a patient. So you're gonna call it a total anterior circulation stroke, and if only 2 out of 3 are present, then we call it a partial anterior circulation stroke. That is just for your routine information. Otherwise, the traditional information, this guys, I would rate this as the most important information per se, because lots of time in questions we tend to neglect this information, though it's damn easy. I mean, anatomy you have already studied very well, I know, but I have usually seen people neglecting this particular part, or I would say domain of the discussion, which is very elementary, right? We tend to focus more on higher cerebral functions which are getting affected, rather than focusing on these baseline data, which can result in error of judgment. So once I warned you, I'm very sure that you are brilliant chaps, you'll pick it up and you will not make a mistake in this. I shall now be explaining to you regarding features of midbrain stroke in a patient. Let's start from the posterior aspect of this diagram that I've drawn. This is going to be the representation of the third ventricle, and the green dots that are shown on the two sides is going to be the trochlear nerve per se. Now you're aware from anatomy that trochlear nerve is the only one having a dorsal origin. In fact, which is the thinnest cranial nerve? It's going to be the trochlear nerve. Which cranial nerve has a crossed origin? You can see that I've shown here the crossed origin of this nerve. So it basically means that the superior oblique muscle of my right eye is supplied by the left trochlear, whereas contralaterally, I mean, when it comes to the left superior oblique of mine, it is supplied by the right. Why that is peculiar is because normally the cranial nerves would be supplying the muscles on the same side of the body, but when it comes to the trochlear nerve, there is definitely a crossing that occurs. In fact, I can just mention the MCQs related to the trochlear nerve per se. If they ask you that which cranial nerve per se has the longest intracranial root, please remember intraosseous root is longest for the seventh nerve. Overall longest is obviously the vagus nerve, that I agree, but longest intracranial root is for the trochlear nerve. This is the only cranial nerve having a dorsal origin. All other will originate from the ventral aspect. If he says which is the thickest cranial nerve, your answer is trigeminal. If he says which is going to be the thinnest one, then the fourth nerve is right here drawn before you. And as I just highlighted, the only one with crossed origin is going to be answered as trochlear. So 4 MCQs of anatomy slash allied sciences, I would say, that's going to be answered as trochlear nerve per se. Now let us move a little anteriorly. This that I've highlighted before you is Edinger-Westphal nucleus. This is from where the oculomotor nerve would be originating, and most of the MCQs of midbrain stroke will actually be having oculomotor nerve palsy. The green structure that I've highlighted once again is the representation of the oculomotor nerve that would be supplying levator palpebrae superioris, then medial rectus muscle, and would also be responsible for mediating the light reflex. The next structure which is highlighted here and is being marked in the form of dots is called as substantia nigra. We study about substantia nigra and the depigmentation of it that happens in Parkinsonism. But today I'll explain to you that even vascular Parkinsonism, that is, if stroke is occurring in the patient in the midbrain, then vascular Parkinsonism can occur due to involvement of substantia nigra. The structure which is present anterior to this is called as crus cerebri. Crus cerebri will be transporting the corticospinal pathway. Yes, the same corticospinal pathway that will start from area 4 of the brain, then go into the internal capsule, then descend into the midbrain, the pons and the medulla, and then will cross over to the other side. In fact, I'll just represent it like this. The red is actually showing the corticospinal pathway. It goes from the midbrain down into the pons, then it goes into the medulla, and then at the lower border of the medulla it will cross over, and obviously the left side corticospinal pathway will control the muscles of the right hand side and vice versa. So this I've just shown to highlight that if the crus cerebri of the left side is affected, then the spasticity that will occur in the patient will obviously be opposite sided, and you can very well see that hemiplegia can not only be seen in a person having stroke related to internal capsule or related to area 4 of the brain, but hemiplegia can be seen even in midbrain stroke as well, because corticospinal pathway is going from this area. Now on the contralateral side also, I'll just mark out the substantia nigra just for symmetry in the diagram. And before I introduce the lesions per se, just be patient and listen to few more anatomical aspects that I want to highlight here. This structure that are now shown in dotted is called as superior cerebellar peduncle, and the main function of superior cerebellar peduncle would be to connect the midbrain to the cerebellum. You see, cerebellum is for maintaining balance, but it obviously needs to get some input. The input is coming via the SCP, so midbrain feeds into the cerebellum via the superior cerebellar peduncle. And now we can introduce a blood vessel here as well, so I'll just draw it in relatively a thick red color, and this blood vessel is called as P1 PCA. I've already highlighted to you that P2 PCA supplies the occipital cortex. The blood supply of the midbrain is P1 PCA, and then it will be having all these perforator branches that would be going inside and supplying the brain parenchyma. Unfortunately, in my patient, this small twig that I've zoomed it at the movement is having some emboli coming from atrial fibrillation. That is, a person was having hypertension, atrial fibrillation, clots developed, and these clots have gone into the brain circulation in P1 PCA, this particular twig that is present most ventrally. As a result of it, there's gonna be definitely ischemic damage to this particular part of the brain. So the shading that I've done at the moment, you can see, is involving crus cerebri, and the second area that is involved here is the green structure, is the oculomotor nerve. Well, what I have drawn before you and is very frequently asked in the exam is Weber syndrome, which is also called as ventral midbrain syndrome. In Weber syndrome, one, you will always be having a ipsilateral third nerve palsy. You can see whichever supply or whichever side blood supply is gone, that side cranial nerve will be involved. Therefore, the question will definitely talk about features of one-sided ptosis and squint in a patient. I have taught you that ptosis and squint can even be occurring in an unruptured berry aneurysm, but I have never talked about hemiplegia in an unruptured berry aneurysm. But in this patient, I will mention that this person will have two things together, ipsilateral third nerve palsy plus contralateral, because crus cerebri was transporting the corticospinal pathway from here down into the brainstem, into the pons medulla, and then crossing over. So this person will be having opposite sided weakness. One, I want you to get used to the fact that in brainstem stroke also hemiplegia will be given, but along with hemiplegia, cranial nerve palsies would come up. So you would immediately come to know that the question is on brainstem stroke, and because third nerve originates from the midbrain, so this is going to be a piece of cake for you, that you can definitely work out the fact that this is going to be involvement of the P1 branch of the posterior cerebral artery. Now I'm gonna show another blood vessel involvement, so I'm just gonna move my discussion a little posteriorly. Just hypothetically imagine that this is the area of the infarct. The area of the infarct that I've currently shown before you is involving the oculomotor nerve and simultaneously involving the superior cerebellar peduncle as well. In this case also, obviously the third nerve palsy will be a classical feature, but over and above this, there will also be manifestations of ataxia. Why? Because the superior cerebellar peduncle feed into the cerebellum is gone, and therefore if cerebellum will not get an input, it cannot give the output of maintenance of balance. Therefore, most of the time they will use the name of this syndrome that you are aware by the name of North-Nagel syndrome. In fact, when they have asked about North-Nagel syndrome, there is always a controversy with anatomy. So I would like to clarify what Harrison is saying for it. I agree to the fact that what the anatomist has said and what I am saying will totally contradict each other, but I would like you to follow what Harrison says. So follow my words very carefully. In North-Nagel syndrome, there will be a development of ipsilateral third nerve palsy, which is traditional for any ventral midbrain involvement. But the additional feature that is occurring in this patient would be a development of a contralateral gait ataxia. Now, why there is a contralateral gait ataxia that I am saying and why the anatomist is saying ipsilateral ataxia is primarily, guys, because in Harrison it is mentioned that this lesion actually involves the area distal to the decussation. You see, superior cerebellar peduncles would also cross over and connect with the different sides of the cerebellum per se. So if right superior cerebellar peduncle is affected, then the input to the left side of the cerebellum would be affected. So therefore, the manifestation that will occur in the patient will be a contralateral gait ataxia. And even if you don't get into the controversy, I would still like you to follow what Harrison is saying for North-Nagel syndrome. It is not given as ipsilateral, guys. It is given as a contralateral gait ataxia. Plus, he can obviously test your knowledge of cerebellar damage by mentioning terms like intentional tremors. So you can see the difference that is coming up by just shifting the damage a little more posteriorly. If you talk about Weber syndrome, there would be hemiplegia. Why? Because crus cerebri is getting involved, corticospinal pathway. But now it is not the corticospinal pathway, but it is the superior cerebellar peduncle in the area distal to the decussation, which is getting affected in this case. I would also like to now draw another anatomical structure which looks relatively reddish in appearance. So this structure that I'm now highlighted a little more distally is called as red nucleus. Red nucleus, the function of this would be that it would be responsible for connecting the midbrain to the basal ganglia, because after all basal ganglia are responsible for planning and programming of movements. So red nucleus is the one that will connect the midbrain per se to the basal ganglia. And for clarity in the diagram, I'm just drawing on the contralateral side. I have shown a infarct deep inside in the midbrain, which is compromising the blood supply of the oculomotor nerve, plus the red nucleus is also gone. This time the damage that will occur in the patient is called as Benedict syndrome. In fact, the manifestations of Benedict syndrome would be classical ipsilateral third nerve palsy that will obviously be given in any ventral midbrain lesion per se, but along with this now the manifestations of connection snapping with basal ganglia would come. So whatever are the features of basal ganglia damage, like he can write ipsilateral third nerve palsy with contralateral chorea, or he can test your baseline knowledge of basal ganglia damage by writing the word resting tremors. Like I've highlighted, intentional tremors are a feature of cerebellar damage and basal ganglia damage will contribute to resting tremors in a patient. So you need to remember Benedict is going to be third nerve palsy with contralateral chorea / contralateral resting tremors. In fact, everything that I've said is contralateral. There's no ipsilateral present here. The terms I want you to remember at this moment, I'll just zoom out of the slide, would be the involvement of Weber syndrome, which is mainly crus cerebri, then is North-Nagel syndrome, which is going to be involvement of the SCP, and then is Benedict syndrome, which is going to be involvement of the red nucleus. In fact, if, and you don't need to draw this one, in case if I extend this infarct further, you can see that this infarct is anatomically very close to substantia nigra. So then even vascular Parkinsonism could be occurring in a patient, and I've used the word vascular Parkinsonism in my description of secondary Parkinsonism. Primary Parkinsonism is Parkinson disease that could be age related or genetic basis degeneration of basal ganglia, but secondary has multiple etiologies like calcification of basal ganglia, drug induced Parkinsonism, and even at the moment stroke, that is vascular Parkinsonism, could also be occurring if the infarct will extend subsequently. Now let us move a little posteriorly in this diagram, and I'll introduce a orange structure here. This orange structure that I've highlighted is called as the pineal gland, and we can be having a tumor of this also that would be called as pinealoma. As this pinealoma will keep on expanding in size, you can very well see it will affect the dorsal part of the midbrain, that is the back side of the midbrain, and the anatomical area that has now been shown and I'm marking at the moment is called as superior colliculus. The superior colliculus is mainly responsible for regulating vertical gaze. Like I can look up and down, I can look towards the camera, I can look down at my computer and right before you. So in this case, because the pineal gland tumor will press on the superior colliculus, therefore the gait of the patient will be affected. In fact, the syndrome that I'll explain to you now begins with the alphabet P. So I usually find people being able to crack the question of Perinaud syndrome by just remembering Perinaud syndrome is a stroke syndrome seen with a tumor of the pineal gland. most of the MCQs of this topic will also describe features of raised ICT, because every time you have a brain tumor, the brain tumor will definitely contribute to manifestations of raised ICT in the form of projectile vomiting or frontal headache developing in a person. And even if it does not describe the features of raised ICT, what you will definitely encounter in this MCQ will be pressure on the superior colliculus, resulting in the following terminology, that is impaired vertical gaze. I also want to highlight that in this particular disorder, the vertical gaze that is mainly affected is the upward gaze. It is not the downward. What is mainly affected is the upward gaze. And because the upward gaze is mainly affected, so therefore the downward gaze component is unaffected. As a result of it, the position of the eyes of this patient might be something like this. Because downward gaze is unaffected, both eyes of the patient have moved downwards. If you go through pediatrics and you study about hydrocephalus, you will read about the sun setting sign. The classical image of sun setting sign is given in OPGAI, the textbook of pediatrics for hydrocephalus chapter. The same sun setting sign which you study in pediatrics, I am today teaching you for a brain tumor, that is penieloma, and the manifestations will be a impaired vertical gaze, where mainly it is the upward gaze that is affected. In subsequent lectures, you will notice I'll describe a condition called as progressive supranuclear gaze palsy, where downward gaze is affected. So I want you to remember both of these hacks. One is downward gaze is mainly affected in PSP, progressive supranuclear gaze palsy, so recurrent falling is seen. And upward gaze is mainly affected in a patient who's having a penieloma, because the questions of these are gonna be relatively longer. Neurology questions are anyway gonna be longer, because neurological examination takes some time to describe. So it could be a 4-liner, 5-liner or 8-liner in the question. But the key aspect is when you read a question related to Parkinson disease features and simultaneously says that person is having recurrent falls to downward gaze, it is progressive supranuclear gaze palsy. And if it talks mainly about upward gaze with features of raised ICT, it would be Perinaud syndrome, which is primarily because of a penieloma. In fact, the features of impaired vertical gaze was one of the options in the exam, in the NEET exam per se. He gave a question which said, all of the following are features of Weber syndrome except. The three choices in the question were ipsilateral ptosis, squint developing in a patient, hemiplegia, and then the fourth option that was given in the question was what I just said, that is an impaired upward gaze. As I explained to you, impaired upward gaze is a feature that you will encounter in dorsal midbrain syndrome, whereas what is shown at the moment and in the focus in the slide is the ventral midbrain syndrome. In fact, these syndrome names are relatively frequently asked, mainly because our examiners love to ask it. So I would definitely like you to practice the information that I have just shared with you. So let's do a quick overlap or quick review of this. And at this point, the query that comes from a lot of students is, sir, I did a MCQ which did not talk about Weber or Benedict, but rather talked about Claude syndrome. Well, guys, Claude syndrome is a additional information that you need to remember over and above what I've said. In fact, this is very surprising question in which cerebellar disease manifestations and basal ganglia features will be given together. I mean, nowhere else will you read that the patient is having chorea with intentional tremors, chorea and a gait ataxia present, because Claude syndrome is a combo. Claude syndrome is a combination of North-Nagel syndrome plus Benedict syndrome. When I taught you North-Nagel syndrome, I was talking about superior cerebellar peduncle getting involved, right? And when I talked about Benedict, B for basal ganglia involvement. So when you read about a combination of North-Nagel and Benedict, well, that is the one that is called as Claude syndrome. So this question is going to be very peculiar because it will be talking about contralateral ataxia. Obviously, that's going to be gait ataxia, but he's also going to talk about a contralateral chorea. So when you read about third nerve palsy with contralateral chorea ataxia, it is Claude syndrome. For Weber, which is one of the easiest ones, I'll just make you practice once again. It is third nerve palsy, obviously ipsilateral, and there's a contralateral hemiplegia. So at the moment, I'm not writing ipsilateral contralateral. I'm mainly focusing on what is the deficit that is seen. When we are going to talk about North-Nagel, which has already been talked about, I have already made you aware of the controversy. It's going to be third nerve palsy with a contralateral ataxia. And this is going to be gait ataxia given, or it's going to be intentional tremors in a person. Why? Because the damage occurs distal to the decussation of the superior cerebellar peduncle. The superior cerebellar peduncles, they actually send information to the contralateral parts of the cerebellum. When it comes to Benedict, B for Benedict, B for basal ganglia. The connection with the basal ganglia is affected, so you would be having features of third plus chorea. In fact, I would suggest you to write it down and practice by yourself so that you are able to remember all this information. You see, ipsilateral, contralateral, you can still remember subsequently. But first is, what are the structures which are getting involved in this case, so that you are able to evaluate or you are able to answer this relatively better. And then there could be a rare scenario about penetrating branches. So I'm again talking about small vessel stroke. You see, P1 PCA is a large blood vessel, then it would be having penetrating branches. Some of these penetrating branches would even be supplying the thalamus. Thalamus is the pain relay center in the body. I drew the thalamus even earlier when I highlighted the fact that it would be present medial to the internal capsule, and just medial to the thalamus would be the third ventricle. I said third ventricle, then the thalamus, then is going to be the internal capsule, and then laterally would be the lenticular nucleus, which is combination of putamen and globus pallidus. So if the blood supply of the thalamus is affected, that's the pain relay center in the body, then there's a possibility that this person can be having very agonizing, I would say, patient might get a feeling as if somebody has poured acid over the body, or somebody is making cuts over the body with a piece of glass. So agonizing, searing pain or burning pain might be described in medical literature for the same, or he might say lancinating pain. That's like somebody is making cuts over the body. The stroke syndrome which is present here is called as thalamic Dejerine-Roussy syndrome. In fact, this per se would be involving the blood supply of the thalamus only. I would like you to remember the specific names that I have explained with respect to midbrain stroke. Try to practice this by yourself so that you can get the orientation right, and he's gonna just mix and match these. Most of the MCQs that are asked are on the easiest one of them. He's gonna mix the information with that of Weber syndrome. If you get Weber right, no, the basic data, that is ventral midbrain, then remaining things will automatically start falling into place. And I'm sure you are aware of all of this from even anatomy, but I would still prefer that you can hand draw this diagram once quickly so that you can get the orientation for Weber. Then you go a little posteriorly, that's going to be discussed as North-Nagel, then is going to be Benedict syndrome, and Benedict syndrome can extend to even cause development of vascular Parkinsonism, and then Perinaud syndrome, alphabet P, that I did not write in this particular discussion because that's relatively easy. No, alphabet P does the trick here. Pineal gland tumor, pinealoma, results in Perinaud syndrome. It's mainly gonna be vertical gaze that would be impaired in this case. I shall now be explaining to you regarding manifestations of pontine stroke. The blood vessel that will be involved in this case would be the basilar artery, and we have talked about the branches of the basilar artery like superior cerebellar or anterior inferior cerebellar artery. But at the moment, I'll just draw these blood vessels before you, especially the basilar artery, and tell you what are the implications that can be seen. The first blue dot that are drawn before you can be taken as the sixth nerve nucleus, and then this one is the seventh nerve nucleus. Laterally speaking, this horseshoe-shaped nucleus that I've highlighted is the sensory nucleus of the trigeminal nerve. You are aware from anatomy that the sensory nucleus of the trigeminal nerve is very big. In fact, it can be present in the midbrain, in the pons, medulla. In fact, it can even extend up to C1, C2 part of the spinal cord. And then is going to be the nucleus of the eighth nerve that will be having two components, that is the vestibular and the cochlear component. So V here stands for vestibular component, C stands for the cochlear component, and they're relatively laterally located. The red structure which is highlighted here is the corticospinal pathway, which is continuing from the midbrain downwards. It will cross over at the lower border of the medulla, and because corticospinal pathway has been shown here, so you can very well understand once again hemiplegia manifestations can be occurring. Now I'll just draw a infarct before you. The way I have drawn this infarct, you can see that it is pairing the sensory nucleus with the fifth nerve. So sensation of the face will not be affected. Hearing in the patient will also not be affected. But what definitely will be seen in this case will be concomitant involvement of the sixth and the seventh cranial nerves together. In fact, what I'm teaching you at the moment is a hot favorite of our examiners. Why? Because concomitant two cranial nerves are getting involved. The name that is to be remembered at the moment is called as Millard-Gubler syndrome. The highlights of this disease would be that you would be having ipsilateral sixth nerve palsy. In fact, you can notice the way I have not shown the involvement of the nucleus, but I have mainly shown the involvement of the nerve fascicle. So I would just like to highlight the fact that it is the nerve that is getting involved, not the nucleus. But when it comes to the seventh nerve per se, it is both the nucleus as well as the nerve getting involved, and that would be lower motor neuron paralysis. In fact, if that sounds surprising to you, I want to highlight that you see, whenever there is a damage to the nucleus of a cranial nerve or the cranial nerve per se, then it is lower motor neuron lesion. Though the topic that I'm teaching you is stroke, but the point is, if you are having damage to the corticobulbar fibers, which are supplying these nuclei, like I've drawn 6, 7, 5, if you are having damage to corticobulbar fibers, that is when you have upper motor neuron lesion of the cranial nerves. But if the cranial nerves are involved per se, or the nucleus is involved, it's going to be lower motor neuron paralysis that will be seen here. So this person would be having ipsilateral 6th and 7th nerve paralysis, with the highlight of 6th nerve fascicle mainly getting involved in this case. If 7th nerve is involved, then the bad news is there would be facial paralysis occurring in this space. But as I explained to you, facial sensation will not be affected in this case. So that's one point to be taken care of. And then since corticospinal pathway is also involved, so there will be a contralateral hemiplegia occurring in this place. And therefore one feature that you would have noticed is that whenever midbrain of the person is involved, you will always be having crossed features. What I mean by the word crossed features is mainly like if there's going to be hemiplegia on one side, then the cranial nerve palsies would be seen on the opposite side. I mean, both of these features are opposite of each other, and the reason for that is anatomical arrangement. Whenever you read a question that deals with hemiplegia and especially talks about crossed features would mean like cranial nerves on one side and hemiplegia on the opposite side, it should always point towards etiology or the source of stroke being primarily the midbrain. I would like to also highlight at this particular juncture, though I've said it verbally, that the nucleus of the trigeminal nerve is really big, and it's going to be spanning through the entire brainstem. The way I have tried to highlight that the trigeminal nerve sensory nucleus, which I can write as 5S, is going to be spanning the midbrain, then is going to be found in the pons. And if you recall, when I drew the diagram of midbrain, the trigeminal nerve nucleus was very much present. In fact, I can just add this up to the diagram here as well, that so that you can just add up to the anatomical domain here. That is the fifth nerve sensory nucleus. Now coming back to the agenda, guys, I want to highlight that it can be present in the pons, in the medulla, and even up to C1, C2 part of the spinal cord. In fact, if they ask you where is the motor nucleus, I'm now writing the word 5M. 5M would mean that the motor nucleus of the trigeminal nerve is bang in the pons, whereas the sensory nucleus spans is this entire area. And in fact, there is a connection between the two also. He has also asked in the exam, what test will you do to actually check this connection? So that would be the jaw jerk. You would be asking the patient to slightly elevate his neck, and then when you hit on the chin, you can keep your finger here and hit with a hammer. It will contribute to opening of the mouth. In jaw jerk, the root value is 5 and 5. It is 5 sensory and 5 motor that will be mediating it. And in fact, if jaw jerk is affected, that means that this connection is not working. The main message from this particular diagram that I want you to remember is one, that in Millard-Gubler syndrome, it is combination of 6th and 7th nerve paralysis that will occur in a person. So I can just jot down the features as well. The manifestations of 6th nerve fascicle damage would be primarily lateral rectus weakness developing in this person. When it comes to 7th nerve palsy, there would be a facial paralysis that would be of the lower motor neuron type and not upper motor, because corticobulbar fibers are not getting involved in this case, and there would be contralateral hemiplegia. Well, the anatomical arrangement, if I just highlight the blood vessel before you in a different color, the basilar artery would be arranged around the pons of the patient in this fashion, and then it's going to be sending up these branches, and any one of these branches can definitely be involved. It was just by chance that Millard-Gubler occurred in a patient. Now I'm going to create a worst case scenario for you. Just imagine that if the main trunk of the basilar artery is involved. Just imagine if the main trunk of the basilar artery is involved, then bilateral manifestations will occur, because corticospinal pathway will be present ventrally in this area. This is the corticospinal pathway of the contralateral side. If the main trunk is gone, then the blood supply, both the corticospinal pathways is gone, and therefore the question will talk about a bilateral Babinski sign. In fact, I want to highlight this fact that whenever you read a question that mentions bilateral Babinski sign present in a patient, that is indicative of the fact that there is a possibility of basilar artery involvement. In fact, I'll just jot down the data before you. This was actually a question, bilateral Babinski sign, and lots of time Babinski sign might be written as only extensor plantars, or he might write the word long tract signs. In fact, corticospinal pathway, Babinski sign, extensor plantars, they all mean the same. Bilateral Babinski sign can be encountered in a patient who's having the involvement of basilar artery. That's the main trunk is getting involved, not the branches that I'm talking about. The main trunk is getting involved. Here, I would also like to mention regarding the case of Michael Schumacher, the Formula One driver who had a nasty crash, And the bad news was that his brainstem was totally smashed. I mean, right from the midbrain, then the pons and the medulla was totally affected. So, because of the fact that his bilateral corticospinal pathway was involved, he was not only exhibiting bilateral plantars but was exhibiting quadriplegia. And simultaneously, because his brainstem was involved, especially the ninth and the 10th and the 12th nerves, along with obviously the midbrain and the pons per se. So the manifestations were can't talk. Why can't talk? Because the 10th nerve is gone. He can't even eat because 12th nerve is also gone, ninth nerve is also gone. So aspiration risk is anyway increased due to vagus involvement and glossopharyngeal involvement in the patient. So can't talk, can't eat, and can't drink are manifestations of mainly the brainstem injury. In Michael Schumacher's case, he was taken as a gone case, though one day his wife realized that only movement that he was exhibiting was his eye movements. Those vertical movements actually made the doctors realize that he was having what is classically called as locked in syndrome. You see, if you just talk about the word locked in, it means that your whole body is as if locked. You can't move your body, but still the cortex is functioning. I mean, the highlight of brainstem stroke is that the damage is in the brainstem, no? So, because the cortex of the patient is still functioning, it was later documented that Michael Schumacher was well awake. He could actually hear doctors discussing his prognosis. He could actually be aware of his surroundings, though obviously he could not communicate. He could not speak. He could not talk, he could not eat, he could drink. So obviously he was put on life support. And it's been so many years after the crash. He's still alive at the moment. In fact, his son has now started racing into Formula One. If you follow Formula One sport per se, but I've given this example just to highlight the fact that the only movement in the body possible in these people is vertical eye movements, and we have special physiotherapists that can actually train these people. In fact, you can see that with technology coming up now, the new editions of iPhone will be having technology where with your eyes you can control your phone, and with the blink of your eye you can change from Facebook to Twitter to Instagram, like that. So similarly here technology was used for him so that he can at least communicate with his family. So the only movement that is possible, I mean, the highlight of locked-in syndrome is bilateral Babinski sign, quadriplegia. He cannot do anything, but he's aware of what everybody is talking about him, and only vertical eye movements are present, by which at least when they talk to him that are you okay, he was trying to move his eyes and saying don't worry about me. Or I mean, that's what they speculated, or that is what his wife interpreted. Obviously that would have an emotional aspect to it, but what I want you to understand is the technical term locked in syndrome can also be referred as pseudocoma. In fact, lots of time it will be a revelation for the family members that all this time we thought the person is in coma, he's not understanding what we are saying, whereas he could actually hear his family members discussing about his state, or his wife crying sitting in front of him, thinking that he will never be able to talk to her. The word pseudocoma and locked-in syndrome both have to be remembered mainly from the perspective of brainstem damage. I also want to highlight that there is a branch of the basilar artery, superior cerebellar artery, that can be involved as well. In case superior cerebellar artery is involved, then one of the highlights that you will always encounter will be development of Horner syndrome due to involvement of the descending sympathetic pathways. I will be talking about involvement of descending sympathetic pathways subsequently also, when I will talk about involvement of posterior inferior cerebellar artery. So 2 times in CNS you will read about especially Horner syndrome manifestations, but along with PICA there will be multiple cranial palsies, that is mainly 5, then 7, 8, 9, 10 and 11 will also be involved. So the message at the moment is, whenever you read Horner syndrome in a case, don't be biased towards only PICA involvement or lateral medullary syndrome, as I'll explain to you. Also keep a watch on the fact that it could actually be a branch of the basilar artery, the superior cerebellar artery, that can also be involved. I shall now be explaining to you regarding features of medullary stroke in a patient. The main blood vessel supplying the medulla is the vertebral artery, and then we have branches also like pica and anterior spinal artery. So let's look at the perspectives. I'll start by labeling some of the aspects or structures in the lateral part of the medulla per se. The first structure that I've highlighted is called as the restiform body, and what you need to remember is that this would connect with the cerebellum. Like I said, cerebellum continuously gets input from the brainstem via the cerebellar peduncles. Even restiform body would be supplying this input, and in case it is damaged, then there would be cerebellar manifestations developing in the patient. The next structure, the red dot that I've shown, is the descending sympathetic pathway, and this will feed the sympathetic chain in the sympathetic ganglia. So the damage to this would result in features of Horner syndrome. The horseshoe shaped structure that I've currently highlighted is the trigeminal nerve sensory nucleus, and in case it will get involved, then the person will be having loss of sensation on one half of the face. This structure that I've highlighted slightly differently from others is called as lateral spinothalamic pathway. When you read the name spinothalamic, it tells you that it is coming up from the spinal cord towards the brain, and this would be carrying two sensations, that is gonna be pain and temperature. And I wanna highlight right now that this spinothalamic pathway has actually crossed over. It is carrying pain and temperature sensation from the opposite half of the body. So in case I show involvement of this pathway per se, then you need to remember that pain and temperature of the opposite half would be affected. No exam in India, especially the neuroanatomical component of exam in India, would ever miss asking this out. What I've drawn before you is called as nucleus of Tractus solitarius. Now, nucleus of Tractus solitarius is related to which cranial nerves? I'm very sure you are aware of this, that the cranial nerve feed that is related to nucleus of Tractus solitarius is 7, 9 and 10, and it's mainly the sensory component of the 7 that would mean taste sensation would be hampered, and ninth sensory component again, because glossopharyngeal nerve has a sensory and a motor component also. So the sensory component, that is taste sensation in the posterior one third of the tongue, would be affected. The next structure which is highlighted here and is being marked at the movement is called as nucleus ambiguus. In fact, I would like you to study these two anatomical structures, nucleus of Tractus solitarius and nucleus ambiguus, very thoroughly, even from the anatomical domain, because they love to ask about it. And the cranial nerves that are related to nucleus ambiguus would be 9, 10 and 11. Now I'm gonna just hypothetically show a area of infarct that I'm gonna shade like this, and this is gonna be technically called as lateral medullary syndrome. You can just count the nerves getting involved here. If you just look at the nerves here, it is 5, then 7, 9, 10 and 11 nerves getting involved. In fact, I would just like to add one more structure here at the movement as an afterthought, that the 8th nerve per se originates at the pontomedullary junction. So 8th nerve can also be involved in this condition. So it will complete the sequence as 5, 7, 8, then 9, then 10 and 11, but 12th nerve is not gonna be involved here. Why? Because the nucleus of the 12th nerve and the 12th nerve will be originating medially. In fact, in the exam they simply gave this diagram and did shading. They had not obviously labeled it like I have at the moment, and the question was very straightforward. I'll just jot that question before you. The question said, which cranial nerve is not involved in lateral medullary syndrome? In fact, he had himself given the name also, though you will notice that in lot of questions he might even use an alternative term which the pathologist would have also said, that is Wallenberg syndrome. I want to highlight lateral medullary syndrome or Wallenberg syndrome. If he says which blood vessel is mainly involved, your first answer is vertebral artery, and if not given in options, then the lateral branch pica is to be answered. The learning at the moment is that the nerves which are going to be involved here, though I've said it couple of times, I hope it's become a permanent memory for you at the moment. Nerve not going to be involved in this case is the 12th nerve, and you will not even get hemiplegia in this case. Why, guys? Because corticospinal pathway is also medial, the area that I've shaded is not having any corticospinal pathway. So I have at the moment also taught you regarding a brainstem stroke which is not having hemiplegia. In all the previous examples you were noticing, Weber syndrome had hemiplegia, Millard-Gubler syndrome had hemiplegia, but when it comes to lateral medullary, hemiplegia is not present. Now I will use a different color to highlight that this area where I'm putting the dots, the green dots, this area if gets involved would be called as medial medullary syndrome, and the moment the person will be having medial medullary syndrome, that is when contralateral hemiplegia will occur. In fact, the details that can be asked would be in the following fashion. Let's just jot it down for the record purpose. Medial medullary syndrome, if he says which blood vessel is involved, I've already sensitized you to this in the earlier part of the discussion, anterior spinal artery. What's going to happen in the patient? Point number 1 would be there would be a ipsilateral 12th nerve palsy, and there would be a contralateral hemiplegia. Remember, crossed features are always going to be encountered in patients of brainstem stroke. So there's going to be ipsilateral 12th nerve palsy, and because that's going to be damn easy for you, he will actually say or he will actually ask you regarding that if you instruct this patient to take his tongue out of his mouth, then the tongue deviation will definitely occur. So he will just play with the game ipsilateral, contralateral. I want you to remember that because this is 12th nerve palsy of the lower motor neuron variety, therefore the tongue deviation will be occurring to the same side. And needless to say, corticospinal pathway involvement will contribute to contralateral hemiplegia. I reiterate my statement, guys. Hemiplegia is not a feature of lateral medullary, it is a feature of medial medullary syndrome. So in a while, I'll actually compile a list of all the times that I've said hemiplegia before you, both in cortical stroke as well as in brainstem stroke as well. Once you get this orientation right, we also need to fill up the data for lateral medullary syndrome. Though MCQs you will be able to solve, but it is my job to actually explain to you how lateral medullary syndrome will evolve and what are the highlights of it. The first and the foremost feature will be involvement of the restiform body. You can just use this diagram as a reference. I'll go from top to bottom. Whatever structures are getting involved, that is from dorsal to the ventral side. So what I'm saying is, if restiform body is involved, then the connections with the cerebellum are affected, and cerebellum is going to be the one that will help in maintaining a balance. So this person would be having a ipsilateral gait ataxia. Please appreciate, this time I did not say contralateral gait ataxia, unlike what I discussed in non-thangial. That is because in non-thangial the damage actually occurs distal to where the superior cerebellar peduncle fibers are crossing. As a result of it, since I said the damage is where the crossing is occurring, therefore contralateral manifestations. But here the restiform body connects to the same side of the cerebellum, so it will be written ipsilateral gait ataxia, ipsilateral intentional tremors in a patient, and ipsilateral hypotonia. In fact, the surprising thing that I'm teaching you is that traditionally in stroke we always read about spasticity, but I'm teaching a stroke in which a person is not having spasticity. The question will begin by describing hypotonia of the arms of the patient. So that's anyway very good pointer, because restiform body connects with the cerebellum, therefore cerebellar manifestations result in hypotonia. Because the descending sympathetic chain in this condition will also get afflicted, that is going to be feeding the sympathetic ganglia after all. So manifestations of Horner syndrome will come in. Features of Horner syndrome that can be described in the question, that will obviously expand the question, can be remembered by a mnemonic by the name of perfect meal. And you know this from your in fact junior classes, that because of the involvement of the Mueller's muscle, which is having a sympathetic mimetic drive, and the descending sympathetic chain is compromised in this case, so there would be a development of ptosis. The Mueller's muscle is not functioning, then would be meiosis. You are aware that mydriasis is related to sympathomimetic activity, it's gone, so unopposed cholinergic activity will cause meiosis. Then is gonna be enophthalmos. This is actually not a true enophthalmos, it's a pseudo enophthalmos. Alphabet A would stand for anhidrosis, that is lack of sweating on one side of the face, and then is gonna be loss of ciliospinal reflex. In fact, 3 MCQs where you are always gonna read about per se Horner syndrome is Pankos tumor in respiratory system, then superior cerebellar involvement, and then pica involvement as well, / vertebral artery, depending on the perspective that he basically wants to introduce in the question. The third manifestation that will occur is very characteristic. In fact, 3rd and 4, if you get a hang of it, my job is done in the following sense. I said in this patient, the trigeminal nerve, 5th nerve, sensory nucleus is getting involved, and even the lateral spinothalamic pathway is getting involved. And remember, lateral spinothalamic pathway was carrying 2 sensations of pain and temperature, and that too from the opposite side of the body. So this is what I'm gonna show. Because 5 sensory is gone, whichever side blood supply is gone, on that side, on the face, all sensations, whether it be hot, cold, tactile localization, tactile discrimination, vibration, in fact all kind of sensation on the face would be lost. But on the body, because lateral spinothalamic pathway was carrying information from the opposite side, and only of 2 sensations, pain and temperature. So here below the neck and on the body, I'm in a dotted fashion trying to show that there's gonna be only 2 sensations lost. Now if I draw a cross like this, you can see that one side of the face and one side of the body is paired, and one side of the face and one side of the body is involved. So the technical term, and that's the main reason why this topic is asked. In fact, most of the MCQs on lateral medullary syndrome will either start with this point or end with this point. So get this fact right, guys, and I've deliberately changed the ink here also so that you can actually remember this fact. Crossed hemianesthesia. Whenever you read a question crossed hemianesthesia described, it means that the question is on pica / vertebral artery. I mean, whatever domain that he wants to ask. First answer is vertebral artery, as I've highlighted a couple of times, but the word crossed hemianesthesia, and this gives more credibility to my statement that I mentioned earlier, that crossed features are always going to be associated with brainstem stroke. Though you will be able to solve the MCQ on the basis of this itself, let's do some more academic exercise here. Seventh and ninth nerves in nucleus tractus solitarius are having the sensory domain. So therefore, since the seventh and the ninth sensory component is affected, you will also read in this MCQ the same patient or crossed anesthesia also exhibiting ageusia. Since eighth nerve vestibular component is mainly involved, so therefore vertigo can also be given. Now you don't need to remember point number 5, 6, 7, 8 that I'll describe before you, but they are being discussed only for academic reasons so that you can get a orientation. Like the motor nucleus of the ninth nerve is gone. Now, what are the implications? You see, glossopharyngeal nerve will definitely play a role with respect to speech production as well. So there will be a paralysis of the soft palate and there would be a change in the voice that would be called as nasal twang to the voice. And at the same time, even nasal regurgitation of fluids can be present. So in this person, you might have to actually introduce tube feeds or even a feeding gastrostomy, because there is even a risk for aspiration in this guy because vagus would be involved. In fact, point number 8 is so debilitating that I'm going to write before you that this person can die. Like in a hot Indian summer, the relatives give 2 sips of water or tea, saying that this guy has not eaten for so many days and doctor is not allowing anything. The guy will aspirate and die. The vagus nerve is responsible for control of heart rate. This is going to be affected. It's responsible for controlling the stomach motility. It is going to regulate the intestinal motility. All these basic things that we don't even think about, like regulation of cough reflex, gag reflex, all of these functions would definitely be lost in the patient. So let me just now mention what is going to actually happen. Because the control of the heart rate is gone, the heart will beat very fast, so you're gonna read about palpitations. Even if he cannot express it, at least there would be a tachycardia in this guy. Then you will notice stomach bloating after every feed because gut motility is hampered, so gastroparesis. You might have to advise enema to be given to this patient. Your nurse would be giving regular enema because he would be having constipation. Apart from this, there would be cough reflex that would be hampered in this guy, gag reflex that would be hampered in this guy. So as I highlighted, aspiration risk will occur in this patient. If you look at the clinical pointers that I have highlighted, development of ipsilateral hypotonia in a patient, and especially a stroke that begins with weakness of the arms, and he himself says that there is a hypotonia present, talks about crossed hemianesthesia, talks about a patient who can die because of risk of aspiration, and cranial palsies that I've highlighted 5, 7, 8, 9, 10, 11, but not the 12th nerve is gonna be lateral medullary syndrome, also called as Wallenberg syndrome. Most of the MCQs can be cracked simply by remembering the number of the nerves or remembering crossed hemianesthesia aspect, and crossed features, as I've highlighted, have come in the discussion time and again. So towards the end of this discussion, I would also like you to practice regarding the times that I've said hemiplegia before you. I told you hemiplegia can be seen due to involvement of middle cerebral artery, which is going to be supplying area 4 of the brain, so understandable. But even P1 PCA blockage contributes to hemiplegia. Remember the aspect of Weber syndrome where crus cerebri was involved? Subsequent to that, when I spoke about bilateral Babinski sign developing in a patient and even a locked-in syndrome, I was talking about involvement of the basilar artery. And in fact, one of the circumferential branches of the basilar artery, when it was involved, it was causing involvement of two cranial nerves together, 6 and 7. That's a hot favorite of our examiners, and that would be Millard-Goubler syndrome. Then I also taught you about anterospinal artery. I had shaded this dotted green in my previous slide itself. The anterospinal artery involvement causes medial medullary syndrome. So let's recall, hemiplegia has been discussed 4 times: MCA, P1 PCA, basilar artery, anterospinal artery, but is not a feature of involvement of the vertebral artery / pica, because vertebral artery will be, or per se pica would be supplying the lateral aspect. That is where the corticospinal pathway is not present. So this is again an important aspect I want you to remember. Hemiplegia can be seen with all of the following except. Just to make you remember all this information, I'm gonna make you practice a crude diagram. Just try to hand draw with me. Please take out a pen, don't be lazy, and just hand draw with me regarding, even if it's in the notes, please hand draw with me and see these anatomical structures that I'm highlighting. The refrigerator that I've drawn is having 3 shelves. It is showing the midbrain, it is showing the pons and the medulla. The blood supply of each one of them has already been discussed. The midbrain would be supplied by P1 PCA. The pons is going to be supplied with the basilar artery. The 2 branches are SCS, superior cerebellar artery, AICA, and the medulla would be vertebral artery, and obviously pica and anterospinal artery aspects have been highlighted. Now, why are you being made to do this is because I want you to remember some cranial nerve numbers so that you can remember, no, if P1 PCA is involved, then the cranial nerves that would be involved will mainly be 3, 4 and 5. right? 3, 4 would be relatively medially located. Sixth nerve nucleus is medially located. 12th nerve nucleus is medially located. Just look at the mathematics. I'm saying 3 into 4 is 12, 4 into 3 is 12, 6 into 2 is 12. I'm not teaching you mathematics. All I'm saying is that all the cranial nerves from 3 to 12, which are multiples of 12 per se, are medially located. I mean, that's one way to remember it, right? Obviously, if you want to learn it from the anatomist from a different way, I'll be glad. The third nerve will be present ventrally, but the only cranial nerve that is present dorsally is fourth nerve. So I have drawn it in a dotted fashion just to remind you that the fourth nerve, the one that has the longest intracranial route, will be the per se one dorsally present. Remember guys, sixth nerve has the longest subarachnoid course. Right, longest intracranial course is per se the fourth nerve. It is subarachnoid course that is of 6. That is the reason why in raised ICP it is the sixth nerve that basically gets involved. Now I'll be drawing that big nucleus that I've already drawn before you. That is 5 sensory. That's gonna take up a lot of space in the midbrain pons as well as the medulla. Whereas the 5M that I'm writing here, and this is 5 sensory. 5M is gonna be located in the pons, and 5 sensory is gonna go up to C1, C2 part of the spinal cord. Let's draw the remaining nerves here as well. This is the seventh nerve, which is relatively laterally located. Then is gonna be 8, 9, 10, and 11. The way I've drawn them before you, especially 8 at pontomedullary junction, then 9, 10, and 11, these branches or these nerves per se and the nuclei are laterally located, and therefore they are at risk for getting involved, since vertebral artery will be supplying mainly the lateral aspect of the medulla, including the branch of it pica. On the other hand, I've already sensitized you to the fact that the blood vessel that is present here is anterior spinal artery. So if you can just get the orientation right, you can yourself see here. The orientation is, if P1 PCA is blocked in a person, what are the nerves that can be affected? 3, 4, 5. If it's a pontine stroke, what are the nerves which are vulnerable? 5, 6, 7, and especially talk about Millard Gubler where 6 and 7 are involved. So facial paralysis is present, but the 5 sensory component was spared because it was relatively laterally located. And then is going to be the aspect of the medulla which has been highlighted multiple times. So this gives you an insight into the anatomy of the brainstem per se, and at the same time also helps you correlate blood vessels with respect to the cranial nerves. I also want to highlight, and you can practice this once again with me. How do you identify that a person is having cortical stroke? I've already told you the features that must be present in a patient together for a total anterior circulation stroke or features for a partial anterior circulation stroke. But if you just want to identify cortical stroke, all the features that I mentioned beginning with alphabet A, that is aphasia or apraxia or abulia. Obviously, that will depend upon whichever part of the brain is affected. Like abulia is a feature of frontal lobe damage, but if these higher mental functions are affected, along with hemiplegia described or arm weakness described or face weakness described, I'm just putting the common presentation. Most of the time or lots of time in a hospital, patient will initially present. Later on, if internal capsule involvement is there, then you will not read about these higher mental functions getting involved. So especially if it's gonna be capsular stroke, or if you read the word lacunar stroke, then capsular stroke will mainly be having pure motor manifestations. I have reiterated this statement. Pure motor stroke, pure sensory stroke is a feature related to internal capsule damage. When it comes to brainstem stroke, you will be having lots of ways to crack this question, but one of the easy words would be crossed hemiplegia. No, why crossed hemiplegia? Because if it's gonna be 6th and 7th of one side, then hemiplegia is occurring on the opposite side. So is the case in Weber syndrome as well, and so is the case in medial medullary also. If it is 12th nerve with tongue division to the same side, then there's gonna be hemiplegia of the opposite side. The workup of these patients will obviously be with respect to a non-contrast CT scan, and as I've started right in the beginning, that non-contrast CT scan findings can be normally in ischemic stroke, but you will not wait for radiological findings of hypodensity to appear. Start thrombolysis within 4.5 hours. The therapeutic aspects of stroke management are discussed in the subsequent lecture. Here I was mainly trying to focus on the anatomical localization. Additional fact that I've already shared with you, but repeating in this slide once again, is in cortical stroke, both the eyes of the patient will be looking towards whichever blood vessel is blocked. So looks at the lesion. Try to remember only one of them so that you can remember the opposite one. In brainstem, patient will look away from the lesion, and when it comes to cortical stroke, it looks at the lesion. That's mainly because of the conjugate gaze that we have now, because frontal eye fields are basic frontal part of the brain that is also responsible for maintaining the visual fields also, and it helps us to look medially and laterally. So if one of the fields is gone, then there would definitely be a problem and the eye will get deviated to the opposite side, that is wherever the lesion is present. And even if you don't get into the anatomy behind it, the main perspective of this discussion was mainly to sensitize you to the fact that the questions of stroke will be relatively longer. It will be a 4 or a 5 liner, but there will always be some key features present. So your objective should be to pick up, is it a brainstem stroke, is it a cortical stroke, or is it a pure motor stroke, that is internal capsule is the one that has been highlighted. And if you get this perspective right, then a lot of things will automatically start getting into the right perspective. Thank you so much for hearing me out in this relatively longish discussion, but I hope this shall be definitely productive to you, and I hope that it will be able to increase your strike rates. Thank you so much for hearing me out.